Before I introduce Dr. Balu Vaidyanathan, who is the star and only speaker for tonight's Fetal Echo Symposium, we will just quickly run through the winners of the papers and poster competitions. The paper competition was decided yesterday, and we had Kaustubh Gupta at 5th, Dr. Rohan Sawant at 4th, Dr. Rajni at 3rd, Dr. Shraddha Somani from JJ Hospital, Mumbai at 2nd, and the winner was Dr. Seema S. Yadagri for her paper presentation entitled Beyond NT. We also have now the poster winners for you. We have Aniket Zope from Symbiosis Hospital, Pune at 5th with his poster on ocular trauma evaluation by ultrasound. We then have Dr. Abhik Dhiman, who came in 4th from Indira Gandhi Medical College, Shimla. His poster was a beautiful one on ultrasonographic features of placenta accreta. 3rd came Subhash Saini, the role of transcranial ultrasound in evaluation of complicated meningitis in neonates and infants. Dr. Guhan from Stanley Medical College came in 2nd with his poster on color Doppler evaluation of orbital vessels in patients with diabetic retinopathy. And the winner of the poster competition for Sonobuzz 2021 was Ravikant UK. He's from MGM Medical College, Indore. And his poster was on the role of transperineal ultrasonography in the evaluation of perianal inflammatory diseases. I'd just like to inform everybody that these posters are still available for viewing at our website, which is indianradiologist.live, and it is available in the poster gallery. Yesterday's winners were Dr. Meenakshi Goyal, the answer breast lipoma, for the quiz contest that we run every day. And the second one run by Dr. Chaitali Parekh, the answer was Morton's neuroma, and the winner was Dr. Chetan KK. We now will move on to the fetal echo section, and I'd like to introduce Dr. Balu Vaidyanathan. I have great pleasure in introducing him actually because he is a wonderful person and currently is the clinical professor of pediatric cardiology at Amrita Institute of Medical Sciences, Kochi. Hello, sir. And after completing his MD from AIIMS, New Delhi, he moved on to pursue his DM cardiology training at Trivandrum. He has been awarded the prestigious Commonwealth Fellowship in Fetal Cardiology from the Evelina Children's Hospital, London in 2007. And he established a dedicated fetal cardiology division at Amrita Hospital in 2008. He has more than 70 research publications and more than 300 professional lectures to his credit. His primary interest is, of course, prenatal diagnosis, neonatal screening of CHD, as well as research in pediatric cardiology. Welcome, sir. This whole session is yours. So I just hand over the mic and the screen to you. So could you please just go ahead and screen share? Yeah.
Yes, I'm going to do that. Let me first check it out with you. Okay.
Yes.
Right.
Fine, yeah.
Sanjeev, can you see my screen now?
Yes, I can see, sir. And we just make it full
thank
screen.
you.
Yeah.
I'll do that.
Okay. Yes, so we are ready to go. Yeah.
Yeah. So I'm all set. Right. So we have about 2 hours. I intend to finish by 10 in my own interest because it's going to be a very long session. And of course, the second session is a bit more toxic than the first one. So we are going to have slightly different timings for both. The first session is basically deals with the diagnosis of the common fetal heart defects. And I am going to follow a very simplified approach based on 3 views. And before I start, I would very much like to thank Dr. Sanjeev Mani and the Indian Radiologist for having me in this wonderful meeting. I heard a lot about Sonobuzz from my friend Mark Sklansky. I think you heard him last week. Mark and I are very good friends, and I know that Mark regularly comes to Mumbai to speak in this forum. So it's obviously a great pleasure to join you all in this. And I hope I can make this approach simple so that I want most of the radiologists who are doing the anomaly scans to diagnose most of the problems which we are going to show today. And just to make sure that you are all listening and not napping off, we will have a couple of 3 of my pictures will be shown again in the end as in the form of a quiz, and you are expected to give the answers in the chat box, and Dr. Sanjeev has got exciting prizes for you. So that's a sort of a incentive for you to stay up and be awake and watch these proceedings. So,
I'm just sorry to interrupt. Can you just, we need your volume a little louder, actually. If you can come closer to the mic, if it's possible.
okay. Is it
This
better
is
now?
better. Yes, sir, absolutely.
Yeah.
Yeah.
Okay. Fine. I'm practically leaning forward now. Right. Uh, right. So, congenital heart defects are one of the most common forms of congenital malformations. Remarkably, in most of the studies published all over the world, the prevalence has been very similar, 6 to 8 per thousand live births, which means that roughly 1 in 120 babies born will have some form of congenital heart defects. Of these, 25% are critical, and which amounts to about 3 babies for every 1,000 live births. Now, in India, about 25 million babies are born every year. So, which means that congenital heart defects perhaps will form one of the largest group of congenital malformations which our pediatricians or neonatologists will be seeing. And mind you, these are all based on data after birth. So it is quite possible that in utero the prevalence may be higher because the number of pregnancies may not actually reach till live birth. Now, finally, this talk ends with counseling. So the whole approach of diagnosis is towards helping to make a decision regarding whether the pregnancy should be continued or whether there should be an in utero transfer for a delivery in a tertiary center and so on. So what are the essential questions which, as a cardiologist or as a clinician, I will be interested in knowing? So before I tell the family, okay, about what I feel about a heart defect, I need to know about what is the diagnosis, how confident and accurate the person who has scanned is about the diagnosis. Then, of course, I should know about the natural history, both in utero as well as after birth. And it is very important to look for the second defect or third defect, because we know that in about 30% cases, congenital heart defects can occur as a part of a multi-system problem. So genetic problems or other extracardiac anomalies may be associated. Then, of course, the decision will depend upon at what gestational age the diagnosis is made. In India, till now, the law says 20 weeks, even though there is we discussed that in different forums, there are efforts to enhance the gestational age for termination. Then what are the treatment options which are available and what are the long-term outcomes? So this is how we actually arrive at the decision. Now, what are the options for management? So once you have a complete cardiac diagnosis and do a complete assessment of extracardiac factors, we know the clinical details, and then you have an understanding about what type of presentation the baby is likely to have at birth. Then the institutional experience of the cardiac center for treating these babies, about the outcomes and the costs which are there, not just for the first surgery, but if there are more operations to follow, what will be the total cost. And based on the gestational age, we can have basically two options and maybe a third. One option is, of course, not to continue the pregnancy if the family doesn't want to undertake a cardiac care after birth. So this will be dependent upon the local, the regional, and the national laws and regulations. And the second option is, of course, to plan the delivery in such a way that the baby is delivered in a cardiac facility, a tertiary facility, and immediate cardiac care is provided without delay. And the third option sometimes is what we call a planned comfort care, which is a situation where a very complex heart defect is diagnosed late in the pregnancy, where termination is not an option. The family is counseled and an informed decision about just to provide basic newborn care. No heart surgery is taken. So that is what I mean by comfort care. So this is a way by which we can actually look at the decisions after the diagnosis. So in order to arrive at these decisions, it is important that we do a proper diagnosis. And that is what today's session is going to focus on. And all of you would have heard each society comes up with their own guidelines. There are innumerable guidelines for screening of the fetal heart. For the cardiologists, we have American Heart Association guidelines. Then radiologists have their guidelines. Then the International Society for Ultrasound in Obstetrics and Gynecology, they have the ICEWOG. They have the ICEWOG guidelines. Then American Institute of Ultrasound Medicine, AIUM, another popular guideline. But what I'm going to do today is just focus on three views of the heart. The first is, of course, the four-chamber view, which I think everybody should know how to get this. Second is the outflow tracts, the left ventricular and the right ventricular outflow tracts, which should be crossing each other like what is shown here. This is a rendered picture, so you can't see the crossing in one single frame. You need two different frames, but we should clearly demonstrate that the LVOT and the RVOT cross each other. And the third view is a three-vessel view. And an extension of the three-vessel view is called a three-vessel tracheal view, or the 3VT view. So we have the four-chamber view, the outflow tracks, which is LVOT, RVOT, and the three-vessel and the 3VT view. So these are clubbed together as three unique views for the fetal heart. First step is the four-chamber view. Of course, for the purists, they will argue with me that there is something else before you even look at the heart, that is the abdominal situs. Yes, I of course do that, and we should do that, but I'm just talking from a very, very basic perspective of a lot of people who are listening to me who can simplify the whole process and make sure that the anomalies which we should not miss are not missed. So the four-chamber view is a very, very important view of the fetal heart. The specific reason why I say so is because the four-chamber view can be used to separate heart defects which can be offered complete correction by way of surgery after birth. If there are two ventricles, then all those defects can be corrected with good results. However, if there is a hypoplasia of one of the ventricles or one of the atrioventricular valves, then you are looking at a very complex heart defect. And these cannot be offered a complete surgical correction. They can only be palliated. So that means that they need multiple procedures, and hence their long-term results are less than optimal. So that's the reason why the four-chamber view has got a great prognostic value as far as the evaluation of fetal heart is concerned. Now, when I list out the four-chamber anomalies, so this is something which for the theoretical aspect, for students who are listening, we can actually have a clear approach. When you look at the four-chamber view, you need to look at different parts of the four-chamber view to make sure that you don't miss anything. So on the left side, the left heart anomalies, the most important and the most severe one is a hypoplastic left heart syndrome. Then you have aortic stenosis, and then we have an entity called ventricular disproportion or asymmetry, where one ventricle, typically the left one, is a bit smaller than the right. So we will discuss the differential diagnosis of that with hypoplastic left heart very soon. On the right side of the heart, you have abnormalities of the tricuspid valve, typically causing tricuspid regurgitation. Then we have this entity called pulmonary atresia with intact ventricular septum. Some people also call it hypoplastic right heart syndrome. And then we have tricuspid atresia. Then the third group is septal defects and the abnormalities of the crux of the heart. And of this, the most common and the most significant one is atrioventricular septal defect. ASD and VSD are not perhaps so important in the fetal life because, it's something which is totally correctable. So the focus is perhaps not on picking a small VSDs and in the fetus. Congenitally corrected transposition or CCTGA has got a very distinctive four-chamber view variation. So we'll just mention that as well. Then we have intracavitary lesions, of which we have most important group is the cardiac tumors, and typically multiple cardiac tumors called rhabdomyomas. A very common problem is echogenic focus, which this I'm not going to cover because of lack of time. Then you look at area around the heart for pericardial effusion, area behind the heart, which we will be seeing in one of these cases towards the end of the lecture. Then abnormal cardiac rhythm, which is going to be covered in my next lecture, and abnormal contractility, which is essentially cardiac function and which is not be covered in this lecture. So essentially, I'll be talking about left heart anomalies, right heart anomalies, and septal defects in this group of four-chamber anomalies. So let us first start with the most obvious anomalies, which is the left heart abnormalities. So in this, I'm going to show you three examples: hypoplastic left heart syndrome, aortic stenosis, and asymmetry or disproportion of the left heart structures. So first, let us see this picture, and this is actually a movie. So sometimes in these sessions, in peak hours, there could be a slow-running movie. Nevertheless, even if you see the picture, it should be all right. Watch this picture carefully, and since it's a webinar and I'm relying on internet for getting this data across, I marked all the pictures as left and right. L is left and the R is right. So you can see also the small, the icon on top, which is showing anterior, posterior, left and right as well, just to orient you. And this is the color of the same picture, same lesion. So in this case, we can see that the left side of the heart, particularly the left ventricle over here, is really small, LV is small. And as we see in this color flow, there is no filling of the left ventricle at all. The entire blood which is coming to the left atrium goes across the foramen ovale to the right atrium and then to the right ventricle. So obviously this is a very severe condition, and this is what is called hypoplastic left heart syndrome. And when we go to the three vessel view in color of the same lesion, the pulmonary artery is marked as PA and aorta is marked as AO. And you can see that in the PA we see the blue flow, which is flow away from the heart towards the pulmonary artery, while in the aorta we see a retrograde flow, that is blood flowing back into the aorta through the ductus arteriosus. And this signifies that there is a complete atresia of the aortic valve, and thus the flow into the aorta is completely sort of maintained by the ductus arteriosus. This is also shown very elegantly in the sagittal view of the aortic arch. The AA is ascending aorta, D is the ductus arteriosus, and we can see that the entire blood flow into the aorta is retrograde and not antegrade. And these features suggest a critical circulation after birth, which is dependent on the patency of the ductus arteriosus. So these two images clearly tell a very severe end of the spectrum, perhaps the most extreme type of heart defect, which is hypoplastic left heart syndrome. Now, there is a specific entity. Now, in the previous picture, I showed that the only way blood can exit the left atrium in hypoplastic left heart syndrome is through the foramen ovale. And in this picture, we can see that the foramen ovale is actually intact. There is no opening at all. And in fact, you can see that the foramen ovale is bulging towards the right side. And in this case, when you look at the pulmonary veins, as seen by the arrows, you can see that they are quite chunky. They're very big, fat pulmonary veins. The reason is because the mitral valve is atretic, so blood cannot go from the left atrium to the left ventricle. So the only exit path was the foramen ovale, and that too is restrictive. So the blood cannot exit the left atrium. Left atrial pressure will increase, and the back pressure will reflect on the pulmonary veins, causing dilatation and engorgement. And this can be identified using by pulse wave Doppler. And if you put normal pulse wave Doppler into the pulmonary vein, this is what you see. You see systolic waves. There are two waves, the S wave and the D wave, and a very small atrial reversal wave, which is shown by this arrow. However, if you have hypoplastic left heart syndrome with restrictive foramen ovale, the pulmonary vein pressure is high, and now you look at the atrial reversal wave here, it's very, very prominent. That's because the pressure is very high, and in atrial systole, the blood will reflux back into the pulmonary veins, causing a prominent air reversal. This is a bit high end, but it's worth looking. It's a very simple thing to do, and just using Doppler to look at the pulmonary veins, and it's useful in many other conditions as well. And this suggests a very severe end of the spectrum. So that's about hypoplastic left heart syndrome. Now let us see another case. Again, the left and the right are marked for you, and you can see that the left side ventricle is small, while the right side ventricle is quite large. But how do you differentiate this picture from the hypoplastic left heart syndrome, which you saw before? So in this, the left ventricle, even though it is small, continues to form the apex of the heart. While in hypoplastic left heart syndrome, the left ventricle is so small that it doesn't form the apex of the heart. The right ventricle forms the apex of the heart in HLHS. So in ventricular disproportion, one factor which differentiates the anatomy is that the LV continues to form the apex of the heart, while in hypoplastic left heart syndrome, the RV will be apex forming. And also, the second fact is that when you look at the squeeze, the contractility, in this condition, the ventricle still contracts, while in hypoplastic left heart syndrome, the ventricle is often hypocontracted. The second feature is by color Doppler, and here we are putting the color Doppler. And as we can see here, in hypoplastic left heart syndrome, there is no flow across the mitral valve. There is typically mitral atresia. So all the blood from the left atrium has to go across the foramen ovale to the right atrium. However, in ventricular disproportion, the mitral valve is patent. And as we can see here in this movie, the blood will flow from the left atrium to the left ventricle. So many a time when you see a smallish left ventricle, you have this tendency to label this condition as hypoplastic left heart syndrome. And please do not do that, because the meaning of HLHS is very severe. The prognosis is bad, while a ventricular asymmetry is often a very common condition, particularly in the third trimester of pregnancy. And if you label it as hypoplastic left heart syndrome, you are implying a very poor prognosis, and that is wrong. And then the decisions may be taken in a very inappropriate manner. So these clues should help you in making the distinction between a true hypoplastic left ventricle versus a disproportionate left ventricle. Now, I'm just going to show this single slide for aortic stenosis, because this is obviously the left and the right ventricles are marked. And in this movie, you can see that the left ventricle is in fact quite severely dilated. And when you look at the contractility, the LV is hardly moving. The right ventricle is moving well, contracting well, while the left ventricle is dysfunctional. And if you look carefully, there are bright patches on the ventricular septum suggesting endocardial fibroelastosis as well. The reason is that, as we can see here, the left ventricular outflow tract, there is a severe stenosis of the aortic valve. There is some antegrade flow, but the valve is severely stenotic. Now, I don't want to dwell more into the management options here. These are situations where some people perform in utero intervention by doing an in utero aortic valve dilatation. It's, of course, a very major procedure, and we will have to talk about this in a different kind of a setting. Okay, so I hope so far things are moving well. Sanjeev, all okay? Okay, I think. Right. So I hope the pictures are all seen well, no problems, because Dr. Sanjeev has not responded back, and I presume everything is well. We are on WhatsApp as well. In case there is a problem with connectivity or anything, he said he will message me. So I presume things are going on smoothly. Okay, now we move on to the second set of problems of the four-chamber view, which is the right heart lesions. In this, I'm going to show you three sets of abnormalities: the tricuspid valve anomalies. He said he will message me, so I presume things are going on smoothly.
It's fine, sir. No problem.
Okay,
Can go on.
now we move on to the second set of problems of the four-chamber view, which is the right heart lesions. In this, I'm going to show you three sets of anomalies: the tricuspid valve anomalies. He said he will message me, so I presume things are going on.
It's fine, sir. No problem.
Okay, now we move on to the second set of problems of the four-chamber view, which is the right. Okay. I could actually hear myself speaking, so I'm just wondering. I just got a message from my very good friend, Dr. Nitin Chaubal, that all is okay. So I am really happy to see Dr. Nitin virtually, at least. Very good friends, and we are missing I think we are all missing each other, I guess. Right. So I'll talk about tricuspid valve anomalies, then of the pulmonary atresia with intact septum. This is sometimes called as a hypoplastic right heart by some of you. And then, of course, tricuspid atresia. I suggest that you pay attention to this group of conditions, because, you may have a surprise later on. Okay, so this is something which is very easy for most of you. A picture-in-picture, one on grayscale on the right side, and the left side, and then the same with color on the right side. So this is something which all of you will put as Epstein's anomaly and severe tricuspid regurgitation. But I just want to sort of put a small pause and suggest to you that all tricuspid regurgitation need not necessarily be Epstein. So I'm just going to bring in one more condition here for the sake of differential diagnosis. So let us look at these pictures side by side. So this is a movie which I have labeled as Epstein's anomaly. And you look at where the tricuspid valve is inserting. So everywhere for your reference, right and left is marked, so you know which is the right ventricle and valve and which is the left ventricle and the valve. And this is the tricuspid valve dysplasia. So here you see in Epstein's, the tricuspid valve is inserting at a much lower level. It is displaced downwards, while in tricuspid valve dysplasia, it stays at its normal level where it's supposed to insert. So when you look at the anatomy of the tricuspid valve, there is a downward displacement of the septal leaflet of the tricuspid valve. This is the hallmark of Epstein's anomaly. However, in tricuspid valve dysplasia, all the leaflets insert at the same level, normal level, so the downward displacement doesn't happen. Now, when Epstein's become more and more severe, the displacement also becomes more and more. So you have the tricuspid valve inserting at a very low level, and it results in a very, very specific entity, which I'm going to show to you in a couple of slides later. So that is the first difference between a dysplastic tricuspid valve and Epstein's. The second is a simple radiological clue. When you look at the origin of the TR jet in color, you see both the pictures, and you will see that in Epstein's anomaly, even though we call it tricuspid regurgitation, the TR seems to be originating somewhere in the middle to apical portion of the RV because the tricuspid valve is displaced downwards. However, in tricuspid valve dysplasia, the TR will begin at the level of the normal tricuspid valve where it should be. It's a very simple thing. So you can see from the still picture very nicely that in Epstein's, the TR jet arises from somewhere in the middle of the RV cavity. Now, the third important part, we often forget the ventricle in Epstein's anomaly. So, in the Epstein's anomaly, the true right ventricular cavity tends to be really small, while in tricuspid valve dysplasia, as you can see here, the RV is just like a normal RV. It's there. It's a normal RV. Sometimes you may even find a dilated RV. So, what is the RV in the Epstein's anomaly? So, in Epstein's anomaly, the right ventricle is divided into two parts. This is because the tricuspid valve is displaced downwards. So, you have the true right ventricular cavity, which is shown by this blue, and then you have the atrialized right ventricle. That is because of the downward insertion of the tricuspid valve. So this is the green zone is the atrialized right ventricle, while the blue is the true right ventricle cavity. So it is quite intuitive that as Epstein's becomes more and more severe with more displacement, the true right ventricle becomes smaller and smaller, and hence that's not a very good situation at all. However, in tricuspid valve dysplasia, the RV is normal sized. Right, so this is the three ways by which you differentiate Epstein's from tricuspid valve dysplasia: the level of insertion of tricuspid valve, the origin of the TR jet in color, and the size of the right ventricular cavity. There is one more method which we will not discuss in the sake of simplicity. Now we have another entity, and here again you see the right ventricle and the left ventricle marked. You see that the right ventricle is distinctly smaller compared to the LV, and it seems to be quite hypertrophied as well. And there is no VSD. So this is, some people may just put this as tricuspid atresia, but if you look at the tricuspid valve very carefully, it seems to be opening. It's small, but it's still opening. And in this case, when you look at the outflow tracts, you see that the pulmonary artery is very small in size compared to the aorta. And as we look at the color into the flow, and we can see that there is a reverse flow into the pulmonary artery, very clearly seen here in these pictures, that suggests that there is no antegrade flow at all into the pulmonary artery. It's all retrograde flow, suggesting that there is pulmonary atresia. So there is a small RV which is quite hypertrophied as well. You have small pulmonary arteries, and you have a retrograde flow into the PA through the ductus arteriosus, suggesting pulmonary atresia. So this is what is called pulmonary atresia with an intact ventricular septum with a smallish right ventricle. So this is another entity where you see the right-sided ventricle is very small here. You can see the right and the left are marked for you. The right-sided valve is not opening at all. There is a large ventricular septal defect as well. the left-sided valve and the ventricle are quite normal. There is a large ASD as well. So this is an example of tricuspid atresia, and there is a large VSD as well. So another common condition, tricuspid atresia with hypoplastic right ventricle. So the differentiating point between tricuspid atresia and pulmonary atresia intact septum with hypoplastic RV is that two differences. One is tricuspid valve typically may be hypoplastic, but it opens in PA-IVS, and of course the ventricular septum is intact in pulmonary atresia intact septum, while in most forms of tricuspid atresia you find a VSD. So here I have drawn two types of tricuspid atresia in this picture. The right ventricle is always small. The tricuspid valve is atretic. So all the blood from the right atrium will have to go to the left atrium, then to the left ventricle, and blood enters the right ventricle through the VSD, which is shown in this cartoon. There are two types of tricuspid atresia. One where the great arteries are related normally, which means that pulmonary artery comes from the right ventricle and the aorta comes from the left ventricle. The second type is tricuspid atresia with TGA, where the right ventricle gives rise to the aorta and the left ventricle gives rise to the pulmonary artery. Now, this is very important looking at the outflow tracts, because typically when there is a tricuspid atresia with TGA, often it will also be associated with aortic arch anomalies also, usually coarctation. So let us see an examples of both. So this is tricuspid atresia with normally related great arteries. I'm showing the three vessel view. You can see that the PA in comparison to the aorta is definitely smaller. And we can see that the two branch pulmonary arteries are also smaller. And the bottom right, you can see the three vessel tracheal view with color. The aorta is big while the PA is smaller. So this is obviously suggesting that there is pulmonic stenosis. So let us see another example. So the right ventricle is very small here. You can see that. Again, you can see that the right ventricle is very small. The left-sided valve is opening very nicely here, while on the right side, there is absolutely no opening of the valve. So it's tricuspid atresia. Now, where the arrow is pointing, that is where the ventricular septal defect is. And if you can very clearly see that the VSD is very small, it's restricting. And you can see the color flow also there, small VSD. So tricuspid atresia with a restrictive VSD. Now look at how the great arteries are related here. Pulmonary artery is large and it is coming from the left-sided ventricle, while the aorta is much smaller and that is coming from the right-sided ventricle. So what is actually happening is the VSD determines the amount of blood which can go into the right ventricle and the outflow which is arising from the right ventricle. So if the VSD is small, the right ventricle will be underfilled, and the outflow which comes out from the right ventricle also will be small. So if it is pulmonary artery coming from the right ventricle, it causes PS or pulmonary stenosis. Or if the aorta is coming from the right ventricle, it will cause coarctation of aorta. That is the reason why in tricuspid atresia, it is not just a four-chamber view, but the outflow tracts also has to be seen. So the two entities have a completely different prognosis and management. Tricuspid atresia with pulmonary stenosis has a far better prognosis compared to tricuspid atresia with a coarctation of aorta. So this is one more condition which I will show. Here you see the four-chamber view in color as well. Here you see that the two atria are seen here, and there is just one single ventricle. Both the valves are opening into the same ventricle. So this is another type of single ventricle, which is called the double inlet type of single ventricle. This is again a common type of single ventricle. So for me, there are different types of single ventricle cases I showed you. I showed you HLHS, I showed you pulmonary atresia with intact septum with hypoplastic RV, I showed you tricuspid atresia, and now I showed you double inlet type of left ventricle. The double inlet LV and the tricuspid atresia tend to have the best prognosis of the lot, because in both these cases, the main ventricle is the left ventricle. However, in hypoplastic left heart, the main ventricle is the right ventricle. Right ventricle is okay in utero, but after birth, we want the left ventricle. That's a stronger ventricle. Okay, so the final group in the four-chamber view is the septal defects and the crux of the heart. And I'm mostly going to focus on the AV septal defect. And I will also show you CCTGA four-chamber view because it's very deceptively looks very normal. So this is an example of a complete AV septal defect. when you look at the center portion of the heart, you can make out the defect. So let us see what are the components of the complete AV septal defect. The first is that there is a large defect in the crux of the heart there. And this is a frame where the valves are open. It's a diastolic frame. And you see a large defect in the crux of the heart with the valves open. So that is the first clue. So it is as if there is a hole, the entire central portion of the heart where the atrial and the ventricular septum meet, it's punched out. The second feature, normally we know that when you in systole, when the valves are closed, there is a normal phenomenon called offsetting, where the tricuspid valve is at a lower level compared to the mitral valve. In AV septal defect, there is a linear insertion of the atrioventricular valves, and there is complete loss of offsetting. The third feature is that the atrioventricular length ratio. Normally, the ventricular length will be more than the atrial length. While in AV septal defect, there is a downward displacement of the valves, so the AV length ratio will be increased. That's the third feature. And the fourth feature is when you put color, you find a single channel of blood flow into the ventricles. Once, instead of two separate channels of color flow, you see a single channel blood flow. And as we can see in this movie, you can also make out some atrioventricular valve regurgitation. So the two important imaging points for AV septal defect are in diastolic frame, you find a large defect in the center of the heart, the crux of the heart, and in the systolic frame, you see the loss of offsetting or the linear insertion. Now, the entity which I showed you was what is called a balanced type of AV septal defect, where the two ventricles were equal sized. Now, look at this type of AV septal defect. Here, you see that the valve is predominantly opening into the right ventricle, which is a large ventricle, while the ventricle on the left side is really small. This should not be termed as hypoplastic left heart syndrome. That's wrong. This should be termed as unbalanced type of AV septal defect with a small LV. This is not left heart hypoplasia. And if you write it, in anatomical sense, you may be okay. You are seeing a small LV, but that is not a correct diagnosis. So please do not label this condition as hypoplastic left heart syndrome. I have seen several reports where an unbalanced AVSD is reported as hypoplastic left heart syndrome. So it's a wrong terminology. So the correct terminology is unbalanced type of atrial septal defect with small LV. This is often a part of an entity called right isomerism, which is we see. Now this is another type of AV septal defect. So you see two good sized ventricles, but you see how slow the heart rate is. So this is typically the type of AV septal defect which is found in left isomerism. Often has associated with complete heart block. See here on the other picture, you see here a very interesting finding. You see two vessels instead of one where the descending aorta is. This is called a double vessel sign. One of this is the aorta and the second is a dilated azygos vein. And this is because the inferior vena cava is interrupted here. So this is the hallmark of what is called left isomerism. So a very deceptive looking picture, looks like AV septal defect, but you have this double vessel sign. Immediately you diagnose left isomerism or heterotaxy. So unbalanced AV septal defect and the AV septal defect with double vessel sign or bradycardia is a part of a heterotaxy type syndrome. The prognostic importance is that these entities are not associated with Down syndrome. So you don't need to do a karyotyping for this condition. However, a balanced AV septal defect has a 50% association with trisomy 21 or Down syndrome. So that is where you would do a amniocentesis and karyotyping. So it's very important to distinguish between AV septal defect occurring in different settings. So I'm not showing the full cases, all the pictures, because I don't like to do that. Because I try to stick to the topic which we are discussing, which is AV septal defect. So please distinguish between the AV septal defect, which you find in trisomy 21, which is a balanced AV septal defect with equal sized ventricles, versus the AV septal defect, which is seen in isomeric hearts or heterotaxy, in which either you get an unbalanced AV septal defect or you get a picture like this, where you have the interrupted IVC with AV septal defect as shown by the double vessel sign. Now this is reverse offsetting. So normally you have the tricuspid valve at the lower level. In reverse offsetting, what happens is everything looks same, but the left-sided valve will be the lower insertion. That is what's shown here. So normally the right-sided valve has a lower insertion. Here, the left-sided valve, that is at the lower insertion. But this is a tricuspid valve because we can see that the right ventricle is indeed there. The moderator band, as shown by that red circle, is there on the left side in CCTGA, where a normal it is on the right side. So in CCTGA, what happens is that there is atrioventricular discordance. The pulmonary veins drain to the left atrium, as we can see by the arrows. However, the left atrium will be connecting to the right-sided ventricle. So the left AV valve inserts the lower level. The right atrium connects to the left-sided ventricle, and hence the right-sided AV valve inserts at a higher level. So that is how you distinguish a normal four-chamber view from the reverse offsetting in CCTGA. Right. So I have covered the first part of my lecture, which is the four-chamber view. I spent quite a lot of time on this because I believe this is very important, and one cannot afford to miss abnormalities of the four-chamber view. Now let us move on to the outflow tracts, and the characteristic feature of the outflow tracts is that they cross each other. The first outflow tract is a LVOT, which goes from left to the right side, and the second outflow tract is a RVOT, which goes from the right side towards the spine, towards that's the pulmonary artery. Right. So this gets a little more difficult how to approach the anomalies of outflow tracts. So I am proposing a very simple algorithm for you. First you do is look at the number of outflow tracts, 2 or 1. If it is 2, look at the great artery relationship, whether they are normally related. Normally related means pulmonary artery is anterior, aorta is posterior. So 2 outflow tracts with normally related great arteries essentially is tetralogy of Fallot, or one of its variants, which we will be discussing. If the outflow tracts are abnormal, the transposition, then you're dealing with TGA. So you can have different types of TGA, TGA with intact septum, TGA with VSD, a double outlet right ventricle with a TGA transposition type relationship of the outflow tracts, or a corrected transposition. So it's very simple. 2 outflow tracts, normally related, mostly fall into the tetralogy of Fallot group, while if it is transposed with aorta is anterior, then it's a TGA group. Then there is this entity called a single outflow tract, and there are only 2 conditions in that is tetralogy of Fallot with pulmonary atresia. The only outflow is aorta and common arterial trunk or truncus arteriosus. Now, from today onwards, I don't want anybody of you to just label any condition where there is a single outflow tract as common arterial trunk. It's absurd and wrong, because we will show you later that many people, in fact, label pulmonary atresia also as common arterial trunk. That's not correct. It should be a single outflow tract, and there is a very clear way by which you can differentiate between the 2, and I'm going to come to that very soon. So this is how I approach the number of outflow tracts and the relationship of the outflow tracts. So let us see the first condition, which is a very easy condition. So you can see the left and the right ventricles are marked. And now you see that as we move towards the outflow, the LVOT, a large ventricular septal defect is coming. And when we put color flow, you see that there is both the ventricles are rejecting into the same outflow. So very classical picture that we see. And in fact, there is even a flow aliasing. And finally, when we go to the 3-vessel view, you see the pulmonary artery is anterior. You can nicely see that bifurcating as well. There is flow as well into the pulmonary artery. And we can see that when you look at the size of the pulmonary artery and aorta, the PA is smaller. So you have balanced ventricles, a large ventricular septal defect. There is an overriding vessel, which is aorta, and there is a small pulmonary artery. Hence, it's the tetralogy of Fallot. That's the diagnosis. So the hallmark feature of tetralogy of Fallot is this. So normally there is a feature in the heart which is called the septo-aortic continuity. There is a continuity between the ventricular septum and the anterior aortic bone. So in tetralogy of Fallot, that is lost. So there is septo-aortic discontinuity. So this is another example in the lateral view, septo-aortic continuity, and here you see the septo-aortic discontinuity, and that results in the VSD. So the aorta moves rightward, which is also called juxtaposition of the aorta. And this is one situation where I make some measurements as well. So in tetralogy, you should measure the aorta, the pulmonary artery, again the aorta, pulmonary artery, the pulmonary valve, the right and the left pulmonary arteries. Now this is very important because a very small pulmonary artery means it's the most severe form of tetralogy. So a very, very useful clue to assess the severity of tetralogy is the pulmonary artery to aorta ratio. Normally, the pulmonary artery is a bit larger than the aorta. So the PA to aorta ratio would be about more than 1. In mild forms of tetralogy, the PA aorta ratio will be somewhere around 0.7 or higher. So that is what we said. PA will be smaller, but the PA to aorta ratio will be about 0.07 or more. While in very severe form of tetralogy, as we can see in this picture, the PA to aorta ratio is less than 0.5, very small. So this is a very blue kind of stuff. So the prognostication or how severe the tetralogy, this only means that the baby is likely to be born with a critical circulation after birth, which means that those babies with tetralogy with severe TOF should be ideally born in a tertiary center. With good treatment, there is no difference in outcomes between the severe TOF and the mild TOF. All of them can be corrected well. And hence, it's important to identify these features only to make sure that the newborn care is given to these patients. So one is the pulmonary artery size and ratio, which I showed. Second is the color flow pattern. Now, if you have a retrograde flow of through the ductus arteriosus into the PA, that's a reverse flow, that indicates that that is a very severe TOF or almost pulmonary atresia. The third thing is to look for pulmonary vein Doppler, and if you get a very high Doppler signals, like the values are shown here, at 20 weeks more than 87.5 centimeters, or at 35 weeks more than 150 centimeters, this may indicate a very severe obstruction. I don't look at the third feature, but rather I focus on the size and the color flow patterns more. This is I just quoted because one study had published this data. Now, how do you differentiate between a double outlet right ventricle and tetralogy of Fallot? So DORV can be of different types, and I am not going to talk about the DORV types in detail here, but this is the type of DORV where the great arteries are normally related, so it's very similar to tetralogy of Fallot. Now, one way to differentiate is that you look at the degree of the aortic override. So this is TOF, and the aortic override is typically 50%, that's it. While in DORV, the degree of aortic override will be much more. Most of the aorta will be coming from the right ventricle in DORV, while in tetralogy, it's just about 50%. So this is one simple way. There are other ways as well, which we are not going to discuss in detail. For pediatric cardiologists, we say aortomitral discontinuity and so on, but it's very simply, if you see the degree of override, that's a very useful feature. Now, I'm going to show you a very important lesion here. Obviously, the four-chamber view looked really normal, but when you look at the first outflow tract, you see that normally the LVOT, you would have expected it to go towards the right side, but here it is not going to the right side. So this is the normal direction of the LVOT if it is aorta. But here you see that not just the fact that the direction is different, but you can also see that the first outflow, which is arising from the left ventricle, is dividing as well. So it's a dividing vessel, and it runs posteriorly towards the spine rather than going towards the right shoulder. So that is classical pulmonary artery from the left ventricle. And the second outflow, as we can see here, is arising from the RV, that is again non-dividing vessel. And the three vessel view, we get the characteristic sign. We see only two vessels, non-dividing aorta and the SVC. So just two vessels in the three vessel view. So these features are characteristic of transposition of great arteries. So the normal heart, you find the LVOT going in this direction towards the right and the RVOT going in this direction towards the left. So they cross each other. In TGA, first outflow is LVOT, which goes right down, tips down towards the spine. And the second outflow is RVOT, which is aorta, running parallel to each other. So there is no crossover in TGA, it's parallel outflows. So this is very, very, very critical in TGA. and to demonstrate the loss of crossing. The anterior outflow in TGA continues as the arch. Normally, the anterior outflow is the pulmonary artery that continues as ductus arteriosus. And here in TGA, that continues as the aortic arch. So there's a very characteristic curved continuation of the anterior outflow of the aorta. That is beautifully shown in this 4D rendered picture. We can see that the anterior vessel is the aortic arch. You can see that beautifully seen, the aortic arch with the 3 branches coming off from it. So that is the classical, the aorta in TGA. It's arising from the right ventricle, and that is the anterior vessel. In addition, in the 3rd trimester, when you image, you should also look at the foramen ovale and the ductus arteriosus in TGA. Some cases you can have restrictive foramen ovale and ductus arteriosus. These are very, very important from a prognostic point of view. This indicates that the baby is likely to be born very severe cyanosis after birth, needing an emergency intervention. So transposition is essentially a very good lesion. This is one of the best conditions to pick up in utero and refer in utero for a delivery in a tertiary pediatric cardiac facility. And if you have a feature like a restrictive foramen ovale, that means that the baby may need an emergency cardiac intervention called balloon septostomy immediately after birth. But that is life-saving, and a prenatal diagnosis can save the baby. So I don't think I will come to the prognostication later, but this is pretty important. Now I'm showing you another case in which there is a transposition-like situation, but you see here that both the outflows are coming off from the right ventricle here. Very nicely seen here. The right ventricle is the one which gives rise to both the outflow tracts. So it's a double outlet right ventricle, and you can see the color flow of the VSD also there. And again, the aorta continues, the anterior outflow continues as the aorta here. So it's a DORB TGA type. And this is the 4D rendered picture. The aorta AO is completely from the right ventricle, while the pulmonary artery is overriding the VSD and predominantly from the left ventricle. So this is the inside of the heart in DORB. You see the right ventricle, the left ventricle. The aorta is completely arising from the right ventricle, while the, sorry, I'll just do that again, sorry. While the pulmonary artery is arising predominantly from the overriding the VSD and arising from both the ventricles. So this is an example of a DRV TGA type. So the 3-vessel view, so which normal 3-vessel view as shown here. The 3-vessel view in TGA typically shows only 2 vessels. But please don't think that this is pathognomonic or very specific for TGA. It can be found in other hearts as well, like corrected TGA, DORB TGA, common arterial trunk, top pulmonary atresia, and so on. So it is not a very specific sign. Now we see a VSD with override, a single outflow tract. So it should be VSD, not VID. I apologize for that spelling error. So here you see only one outflow tract, and when you look at the color flow, you see that there is one outflow tract, there is a blue flow, that is the aorta, while there is a retrograde flow, that is a red flow into the other outflow tract. This means that there is a large VSD and overriding aorta. The pulmonary artery is receiving blood from the ductus arteriosus in a retrograde manner. So this cannot be labeled as a common arterial trunk. So this is an example of VSD with pulmonary atresia. So antegrade flow into the aorta, while there is a retrograde flow into the pulmonary artery. So this is the second entity where there is a VSD with a single outflow tract. That's a single outflow tract. There, the pulmonary artery is arising from the single outflow tract. See, the direction of color flow is same in both. So that is called common arterial trunk. So how do you differentiate between truncus arteriosus and top pulmonary atresia? In both conditions, there is a single outflow tract, which is continuous as the aorta. In the common arterial trunk, the direction of flow is same in both the arteries, as we can see here, while in VSD with pulmonary atresia, aorta gets antegrade flow, while pulmonary artery gets the retrograde flow through the ductus arteriosus. This is how you differentiate between common arterial trunk and top pulmonary atresia. So whenever you see a single outflow tract, please do not label all of them as a common arterial trunk. That is completely wrong. Common arterial trunk means there is one outflow which continues as aorta. Pulmonary artery also arises from the same trunk. This slide I'll skip. So now we move on to the final view. So I have covered anomalies of the four-chamber view, and I have covered common anomalies of the outflow tract. The final is the anomalies of the three-vessel view, which is shown here. The P is pulmonary artery, A is aorta, and S is the superior vena cava. So anterior is pulmonary artery, middle is aorta, and the most posterior is superior vena cava. And then you have the three-vessel tracheal view, in which the pulmonary artery continues as a ductal arch, and aorta continues as aortic arch, and the two arches will join on the left side of the spine, so in a classical left patch. So there are a large number of anomalies of the three-vessel view, which includes abnormal vessel number. The most common example is persistent left SVC. Then abnormal vessel size, a small PA, a small aorta, a large SVC, and so many things. Abnormal color flow patterns, abnormal vessel course or alignment. That is classically the anomalies of the arch-sidedness, like right arch, double arch, and so on. And then there are certain other structures like the left brachiocephalic vein, which I'll briefly show towards the end in the last case. So the three-vessel view, in fact, holds the key to the all the outflow anomalies. So many conditions can be diagnosed. This is one condition which I don't want you to miss. So I'm going to discuss this in some detail. So you see the four-chamber view, and you can make out that the left ventricle is slightly smaller. The left and the right are marked here. There is a forward flow into the left ventricle. The three-vessel view, you find that the aorta, which is seen in the center, is definitely smaller compared to the pulmonary artery. A very useful tip to look at the size in the three-vessel view is to look at the size of aorta and SVC. Here you see the SVC on top, aorta in middle, PA is bottom, and you see that the aorta is almost the same size as the SVC. So that means that the aorta is really small. And then when we move up to the three-vessel tracheal view, you see the aortic isthmus, which is shown by the red line, and the ductus arteriosus, which is a green line. And you see that the aorta is really tapering down, and the aortic isthmus is really, really small. And what we do is the isthmus to duct ratio, and that is, if that is really small, less than 0.7, that is something which is very ominous, and that is suggesting that the possibility that there is an aortic coarctation. And then when we put the color flow, you see that in the isthmus side of the aorta, there is a significant narrowing where there is a significant bottleneck. So all this is like quite becoming more and more clear. There is relatively smallish left ventricle. The aorta was small in the three-vessel view. And when it comes to the three-vessel tracheal view, we find a real small bottleneck at the level of the isthmus. Confirmation of the diagnosis is made by using the sagittal view of the aortic arch. And you see the narrowing there. That is very highly suggestive of coarctation of aorta. The last picture is a rendered picture showing the 3D picture. You see both the aortic arch and the ductal arch. The ductal arch is the one which is marked as D, just below. It also emphasizes the fact that in the fetus, since the ductus arteriosus is open, coarctation will never ever manifest. It will only manifest after the baby is born when the ductus arteriosus closes. So then it will be a severe obstruction to the aortic flow. So coarctation is one of the most difficult diagnoses in the fetus, and the screening is by the four-chamber and three-vessel, which shows smaller left heart structures. Three-vessel tracheal view with the isthmus and isthmus deck ratio gives us a solid clue. And if the isthmus becomes smaller and smaller with the shelf, which I showed in the sagittal view, it becomes a sort of confirmatory diagnosis. There is the elder brother of aortic coarctation, and that's called the interrupted aortic arch. Here you see that the aorta doesn't even continue down. It's just the PA and the ductal arch which is continuing down. And the aorta, the ascending aorta, just continues into the head and neck as the nominate artery. And when we look at the sagittal view, you see the interruption there, complete interruption there. It's a very nice 3D rendered picture. You see that the ascending aorta is completely stopping after the innominate artery. You can see the innominate artery IA, and then there is aorta is totally is cut off. The descending aorta is supplied by the ductus arteriosus, which is by D. This is a very good, useful picture which shows the anatomy with so much clarity. This is a 3D rendered picture, and this is actually published in Circulation as an image. The usefulness of 3D for the diagnosis of interrupted aortic arch. So this is a severe condition, but it is a totally correctable condition. So it's important to, this baby in fact was delivered in our center and operated, and now is about 4 years old, doing really well. So it's an important diagnosis not to be missed. So in coarctation, you find that the aorta is small with an isthmus shelf, while in interruption, classical feature is this reverse flow. You see the red flow on the aortic side. That is because the aorta is completely not extending down. It's retrograde flow through the ductus arteriosus. The second picture is very critical because it suggests that the baby is going to be born with a severe critical circulation after birth. Then we have this entity called right aortic arch. So this, to compare the two pictures, S is superior vena cava, A is aorta, and P is the pulmonary artery. In this picture, you find that there is an increased gap between the aorta and pulmonary artery, which is shown in these pictures as well. That is because normally the aorta moves rightward towards the leftward, towards the PA in the left arch, but the right arch, it stays on the right side. So there is an increased gap between the aorta, PA and aorta in the three vessel view. So very useful clue for the right aortic arch. Then this is a normal left arch. We see the classical V shape, but here you see a classical U shape. That is the right aortic arch with the left side ductus. This becomes more obvious with the color flow. So this is a normal left arch. The pulmonary artery and the aorta join as a V-shaped structure onto the left side of the spine, while in the right aortic arch, classically, the aorta stays on the right side and you get a classical U-shaped sign. That is the right arch with the left-sided ductus. Now, this is generally a very benign condition. Right arch with the left-sided ductus. Rarely, if there's an aberrant branching pattern, it may cause a vascular ring. And the second importance is that it has a small association with 22q deletion syndrome or DiGeorge syndrome. So some people recommend genetic testing for these conditions. Now, this is another example. Looked very similar to the right arch from these pictures. But when we moved toward the 3VT view, we started seeing more and more pictures. Like finally, we saw this picture. This is like a bit more complex. So let us see the 3D rendering of this. So these are the 3D rendered pictures. So here you have a lambda sign. The aortic arch, which is A, divides into a smaller left arch, which is shown by the letter L, and the larger right arch is shown by the letter R. These two arches form a complete ring around the trachea, which is shown by the letter D. The ductus arteriosus also is there that completes the lambda, that is D. So this is a complete vascular ring, and the trachea will be in the center, and typically it causes tracheal compression. So this baby is likely to be born with stridor. So the distinguishing feature between a right arch and a double arch is that in the double arch, the ascending aorta divides into a smaller left arch and a larger right arch. While in simple right arch, the ascending aorta just continues as the arch on the right side. That's all. There is no bifurcation of the aorta into the two branches. So this is a situation where 3D, 4D rendering is really helpful, and sometimes it gives us very confirmatory pictures. Now the last part of my lecture covers this anomaly. This is for the slightly higher end users and who have started looking into the brachiocephalic vein. So brachiocephalic vein or the innominate vein is seen higher up from the three vessel tracheal view. It is formed by the confluence of the left jugular and subclavian veins. It crosses the mediastinum and drains into the SVC like this, anterior to the aortic arch. So let us see this case where was referred as for right heart enlargement. So you see that there is a larger right-sided ventricle here. And when you looked at the three vessel view, you could see that there are four vessels. In addition to the SVC, aorta, and PA, there is a fourth vessel. And when we look at the direction of flow in this color flow, you see that there is a distinctive difference. One is red color, that's really unusual. And when we looked at the bicaval view, you found out that the SVC was large, very large SVC. So there is right heart enlargement, there is 4 vessels in the 3 vessel view, and there is a dilated SVC. When we looked more carefully at the 4-chamber view, we found out certain additional clues, that is the area behind the heart. We could see some additional clues. And finally, when we looked at the brachiocephalic vein, you saw that that is hugely dilated. That red thing which is draining is a dilated brachiocephalic vein. So the rendered picture, this is an example of a supracardiac TAPVC to the SVC, anomalous pulmonary vein drainage. So the differential diagnosis of 4 vessels in the 3 vessel view is persistent left SVC versus TAPVC. Now, how to distinguish between the two? A dilated brachiocephalic vein in this setting, 4 vessels in 3 vessel view with dilated brachiocephalic vein is TAPVC. The vein of Galen malformation typically doesn't cause 4 vessels in 3 vessel view, but it will cause a dilated brachiocephalic vein, but there won't be 4 vessels in the 3 vessel view. In a persistent left SVC, classically the brachiocephalic vein will be absent. So if you have the situation where you have 4 vessels in the 3 vessel view, and you have to differentiate between a persistent left SVC and a supracardiac TAPVC, look at the brachiocephalic vein. Dilated BCV is TAPVC and absent BCV is persistent left SVC. You can also look at the direction of flow of the 4th vessel in the 3VT view. In the persistent left SVC, it drains towards the heart, so blue, while in a supracardiac TAPVC, it's a vertical vein, so it drains away from the heart, so it will be red. So the clues for supracardiac TAPVC are area behind the heart, showing a collecting chamber or a common chamber as shown by the arrow there. 4th vessel in the 3 vessel view there, a dilated SVC in the bicaval view there, and the dilated brachiocephalic vein as shown there. So it's just putting all these pictures together and making a diagnosis. In fact, this was made by one of a very good radiologist from Maharashtra near Mumbai in Nashik, and at her request, so I've given a number of clues. Maharashtra, Nashik, her. So maybe some people may know, maybe she also is listening to this, but I won't say the name because she has prohibited me from saying this name. So these pictures were taken from one of my very, very good friends practicing in Maharashtra. Right. So that is about my cases. So maybe, okay, how do we counsel? So that is very quickly, I'm going to sum up this. It's about 9:20. So taken about an hour for this lecture, which is all right. So what we need to do is that we start holistically, the fetus as a whole. So even before you come to the heart, you need to look at extra cardiac factors, genetic factors, and so on. That is your job, NT. And if you are looking at multi-system problem, then you should do an amnio, get the information whether there's an associated genetic problem and so on. Then the 4-chamber view is a really mighty step for you because it helps to differentiate between the complex and the lesions and the correctable problems. The outflow tracks, the number relationship, in utero progression, whether stenosis progresses to atresia, and whether the newborn can have a critical presentation like a TGA, coarctation, interruption. So that's how we proceed. The 4-chamber view, as already shown, will give you clues towards very severe heart defects, which cannot be given of total correction. This is very, very important to start there. While the outflow tracks typically gives a clue towards more correctable problems. Now, every TOF, every TGA, every coarctation deserves to be corrected. So it's very, very important that you as a group, I know that more than 500 people are listening to me tonight, and I want all of you to take home this message that these are all completely correctable problems everywhere in India. There are about 35 pediatric cardiac centers now. It's important to refer these cases to the pediatric cardiologist. So this is something which really I don't mind if somebody copies. It's for you only. I'm not going to talk about entities like small VSD or bicuspid aortic valve. a lot of people are mentioning bicuspid aortic valve and all in the fetal echo. I think it's really not really needed, because there's something which you have to leave to the pediatric cardiologist also. It has no prognostic value in utero. So it's better not to talk about lesions which you are not sure about. Coarctation, TAPVC, they have all excellent prognosis with correction. So is a large VSD, because there's something which you have to leave to the pediatric cardiologist also. It has no prognostic value in utero. Sanjeev, can you just stop the audio from your end, because it's reflecting back to me now? Okay, thank you. Right. Now we have entities like tetralogy, TGA, most forms of DORV, all forms of TAPVC, coarctation. Please, all these cases deserve a referral to a pediatric cardiologist. These patients survive surgeries, and 95% of these cases survive to adulthood and do very well. So I think from today, if you pick up these conditions, make it a point that you refer to the pediatric cardiologist, particularly lesions like TGA. When you have lesions like TOF, pulmonary atresia, common arterial trunk, then tricuspid atresia, and so on, these are a little more complex because they need more than one surgery. Some of them, like tricuspid atresia, may need multiple reoperations. However, their survival is good in the modern era. They do reasonably well, but of course, they need multiple operations. So that's why I put the prognosis as fair. Then there is this group, hypoplastic left heart syndrome, heterotaxy, which is also called the isomeric heart, unbalanced AV central defect, complex types of pulmonary atresia, and severe form of Epstein's anomaly. These really have very suboptimal prognosis. So I think it's important that you all stand up and try to diagnose these problems early, rather than missing them and coming up with diagnosis at 34 weeks, and then nobody knows what to do. So I think it's very important that these lesions, if the family is not keen to continue pregnancies in these cases, the diagnosis should be made very early. In fact, these are the situations where I would endorse first trimester diagnosis. There is no fun in making a diagnosis of TG in the first trimester and the pregnancy ending in termination. So it doesn't really make much sense. So the first trimester or early diagnosis should mostly focus on the most severe spectrum or multi-system anomalies, while the other conditions, the correctable problems, one corrected, should be referred to a pediatric cardiologist and or a cardiologist. Right. So this is the lecture is going to end here, and it's and we are going to have a quick recap. And for the audience, this is Master of Ceremonies will be Dr. Sanjeev Mani, and he is going to give you prizes. I'm not going to give you prizes, but I'm going to show you the pictures.
So sorry to interrupt, but before you start, would you like to take a few questions, or you want to do it after the quiz, sir?
Maybe whatever. Then shall I show the quiz and then take the quiz?
All right, sir, we can do that. So friends, we are just starting the quiz. The first answer in the chat box, the first correct answer in the chat box will win, and we will be declaring these results tomorrow. All right. So I think, sir, three quizzes you're doing, right, sir?
Only three questions.
Yeah.
In fact, it's just a recap. It's just Sanjeev a test whether they have been sleeping or they have been listening.
All right, sir. Let's go on. You can start, sir.
First question. This is case 1. The right and the left are marked. So there is a picture in grayscale, and there is a there's a picture in with color flow mapping as well. So all you have to do is to type the answer. What is the diagnosis? 2 words is enough for me. Okay. So I will be showing the answers in the end after the 3 cases. So I'm going to give them at least 15 to 20 seconds to view this picture. So people who have got poor connectivity also may be lagging behind. So I can just show them. We'll wait. Okay. Sanjeev, can I move on to the next one? Enough time? Okay, I think now I will move on to the second question. Right. So this is a little more. So this is an outflow anomaly. The first one was a 4-chamber anomaly. So the questions I have put in such a way that throughout the lecture you are listening. So I have taken the first question from the first segment. This is case 2. from the second segment of outflow anomaly. There is a picture of the LVOT view on your left side. The right and left are marked, and there is a 3-vessel view on the right side. So what is the diagnosis? So this is a very classical case. So, and don't complain that these pictures are not helping. They're very classical pictures as well.
Yeah, so you can move to the third case. They've been paying attention.
Right. This is the third case. So there is a 3-vessel view which is shown here. And there is a 3-vessel tracheal view with color, which is shown here. So this is from the 3-vessel tracheal view, 3VT view anomalies. So you can make the diagnosis of this entity as well. Very simple condition. I think I showed all the 3 pictures in my presentation as well. Okay.
Yes, sir. We've got the answers also. So
okay.
We can.
So should I give the answers or should I not give the answers?
You can give the answers now, sir, and we'll select the winner and announce tomorrow.
Okay. So the first case is, of course, tricuspid atresia. This is a tricuspid atresia. We can see that the tricuspid valve is completely closed. There is a large VSD as well. And the second case was TGA. This is TGA. The first outflow LVOT view was bifurcating. That's a PA. And 3-vessel view, you see only 2 vessels. That's the anterior vessel aorta. The third case, the diagnosis was right aortic arch. So in the 3-vessel view, you could see that there is a large gap between the aorta and PA. And in the 3VT view, instead of the V, you could see the U-shaped arch. That is the right arch with the left-sided ductus arteriosus. Right. So I have sort of completed the first presentation. So maybe I can take some questions from the chat box now. Oh, it's really.
I'll just go through the questions. It's right at the bottom. Just give me a moment, sir.
Yeah.
And others also can please retype your questions. It's been flooded with the answers in the chat box. So if you could just retype your questions, it will be nice when sir can answer them.
My goodness, we have arrhythmias after this. Maybe you can seriously think about giving me half an hour on another day also, if you want.
Yeah, we'll work that out, sir. We'll do that. All right, I
am a very slow speaker, Sanjeev.
No, so we need it that way. It was very nice. So you've just walked us through almost every cardiac condition we all have seen, actually. So it's been a beautiful demonstration, sir. Okay, I'm still getting some answers. So we're just waiting a minute more for any questions.
No
Everyone,
problem.
please type in your questions in the chat box.
I am willing to take arrhythmias fresh as well in your time, because I'll leave it to you. Generally, I can talk, but some people from Nashik know that I can speak for a long time, but it's very hard for people to focus on a very long cardiac session.
Okay, so
it's good to,
name of Nashik radiologist seems to be the 4th quiz, sir, but we'll leave it for some other time. Yeah.
If I will be, if I reveal that, then I will be sort of, I will be kidnapped from Mumbai and taken else somewhere. So I'm not going to talk.
Okay, so we're getting some questions. Yeah.
I think some people will know, but radiologist from Nashik who diagnosed TAPVC, I think many people will know.
Okay, sir. So we have questions coming, sir. One is from Shilpa. She says, how do you diagnose restrictive foramen ovale and restricted ductus?
Wow, that's a very good question, Shilpa. Great. So, yes. Now, when you talk, I'll talk about both separately. First, let us talk about restrictive foramen ovale. Now, restrictive foramen ovale can occur in 2 settings. First, it can occur in the setting of an associated heart defect. So, in this presentation, I showed you an example of hypoplastic left heart syndrome with restrictive foramen ovale. And I showed that the classical feature of that was the normal pulmonary vein Doppler. In that setting of hypoplastic left heart syndrome with the restrictive foramen ovale, the left atrial pressure was elevated because there was no egress for the left atrial blood. The same thing can happen with the right heart lesion also. For example, if you have tricuspid atresia, or you have maybe even Epstein's anomaly, if the foramen ovale becomes restrictive, then what happens is the right atrial pressure will go up and the back pressure will reflect onto the ductus venosus. So when you do the ductus venosus or the umbilical vein, you will get a very prominent reverse A wave. That suggests a very high pressure, and these are the fetuses which can eventually go on to develop hydrops fetalis and in utero compromise. So this is the second setting. So one is the setting of left heart lesions, second is the setting of a right heart lesions, and the third is with the normal heart also we can have a restrictive foramen ovale. Typically occurs during the third trimester. We don't know why this happened. It's a mystery. But it can also seriously compromise because we know that the foramen ovale is important for the fetal circulation. And the foramen ovale is restrictive in the fetus. The high pressure and high saturated ductus venosus blood cannot go across. So that can compromise the circulation and it can sometimes lead to hydrops as well. So this has been described by Mark Jevalik, who is a Belgian cardiologist, in a paper. I think it was published in European Journal of Cardiology, the restrictive foramen ovale in normal hearts. Very rare entity, but I think these are things which you should look for in the third trimester. So what are the clues for restrictive foramen ovale? One thing is that there will be a typical bulging of the foramen ovale towards one of the atrium. The second feature is that the free movement of the flap may sometimes be not happening. It will be the movement of the flap may be reduced. And the third thing which I haven't really understood is the abnormal angle of insertion of septum primum. I think it's a theoretical point, but I go more by the unusual bulge and the restrictive movements. So this is about foramen ovale restriction. It's a far less common condition compared to the restrictive ductus arteriosus. Restrictive ductus arteriosus, of course, is a very important condition, and this can occur again idiopathic without any particular reason, or it can also occur in the setting of where the mother has been given medications like indomethacin or some kinds of non-steroidal anti-inflammatory drugs. Here, the ductus arteriosus constricts. So what happens is it results in a kind of a right ventricular outflow obstruction. It stresses the right ventricle. It causes the RV to dilate. Sometimes it can produce TR, severe TR and right heart failure and hydrops. So this is because the most of the right-sided output in the fetal circulation doesn't go into the pulmonary arteries. It goes mostly into the ductus arteriosus and then into the descending aorta. So when there is an in utero restriction of ductus arteriosus, it increases the afterload of the right ventricle, causing its dilatation, dysfunction, TR, and right heart failure. I had actually examples of this, but I think there is a limit to the number of images I can put in even in a 2-hour session. So if I had a whole day to talk to you, then I would have shown you these beautiful cases of both this. So maybe, Shilpa, I think I'll remember you. One of the longer sessions with Sanjeev, which we will surely do, we will have a full day session in which I will show you these rare entities, but it is very good to remember. So whenever you have RA-RV dilatation and TR, you should look for the RV outflow and ductus constriction, particularly in third trimester.
Okay, so there's one more question. Thank you for that. Harsh Reddy is asking, can you explain a little bit about Z scores and what is taken as normal?
Very good, Harsh. Excellent question and very, very important. I think it again tells me that there are people who are measuring the cardiac structures. Now, Z score is nothing which is specific to fetal echo, or it's just an expression of your measurement. Now, when you say Z score, we say we have an observed value. That is what you are measuring. Let us say you are measuring the aorta and a 30-week gestation fetus, and you got a number. So that is your, let us say A is your number that you measured. Now, what is the expected normal for the gestation? That is B. So let it be 6, and so your measured value is 5. So your measured value is smaller than the expected value. So the Z score or standard deviation score is like the measured value minus the expected value divided by a standard deviation score. in very simple terms, it means that when this ratio is giving you a negative number, that means that your measurement is smaller than expected. And when this ratio is giving you a positive number, it means that your measured value is larger than expected. Now, if you follow statistics, there is something called the 95% confidence limits, or what we call the Bell's curve. So Bell's curve means that the value, whatever, you're expressing this as 95th centile with a confidence limit, which means that your value will be within 95% of all the measurements of for that particular gestation. So in simple terms, if I say that the average height of an Indian man is 5 feet 9 inches, then the 95th confidence limit will be between 5 feet and 6 feet, which means that 95% of Indian adult males will have a height between 5 feet and 6 feet. If you have somebody who has a height of 7 feet, obviously he is outside. He is much taller, and his set score for his height will be something like +4 or +5. If the height is 4 feet, that will be -3 or -4. That is outside the confidence limit. So this is what is called Z score. Very, very useful. It tells you the comparison with normal. And when you serially measure a particular value, and if the Z score becomes more and more negative, that tells you that the structure which you are measuring is progressively shrinking, becoming smaller and smaller, and then you are really concerned. For example, if the aorta is becoming serially small with, let us say, repeat measurements, then the probability of having coarctation is much, much higher. So is it clear?
So that was fine. There's Lakshmi was added on to that question and just asked you for the planes to take the measurements. What planes to take the measurements?
Okay, very good. Right. Lakshmi, I don't really do a lot of measurements, but the two structures which I always measure is the pulmonary artery and the aorta, and that should be done in the 3-vessel view. Now, you always, for the outflow tracts, you measure them in systole, which means the semilunar valve should be fully open. So the blood is ejected fully and you have the maximum measurement. That's number one. Number one principle is outflow tracts measured in 3-vessel view in systole, and you should measure from the inner edge to the inner edge. So you get the full vessel. Typically, the pulmonary artery is measured midway between the valve and the bifurcation. So that is midway between the valve and the bifurcation. And the aorta is measured exactly at the same plane where you measure the pulmonary artery, draw it tangentially down. So that is where you measure the PA and aorta. The isthmus I showed in the 3-vessel tracheal view, where the V is, I think I showed in one of my pictures how to measure the isthmus and the duct. That is almost near the end of the V. You measure the isthmus on the aortic side and the duct on the ductal side. This is another measurement which I take. Then in the 4-chamber view, you can measure the atrioventricular valves, the mitral valve and the tricuspid valve. Again, it should be measured preferably in an apical 4-chamber view, but lateral is also okay, or even a basal is fine. You measure in the diastole. For AV valves, always it's in diastole with the valve fully open. And you should measure from the hinge point. So I think maybe I may need to demonstrate this. Unfortunately, I don't think it becomes complex to open. Really, somewhere I have to run, really look into my laptop. But I think it's in the diastolic frame at the hinge points. Again, the Z scores are available. So I think these are some of the good structures which you worth measuring in the heart, the biometry. Of course, you can measure a lot of other things, but this should be enough for the routine cases.
So Zarina is asking what is the difference between PLSVC and supracardiac TAPVC?
Oh, I think I measured
you covered this, I think, sir.
In very simple terms, persistent left SVC, even if you miss, I'm not going to hang you. But a TAPVC, if you miss, that's something which you should not miss ideally, because TAPVC is a critical heart problem which needs surgery and can be corrected with good outcomes. So obviously it needs a pickup. So the only way you can do that is to look at the pulmonary veins. And I think I gave you abundant clues towards how to diagnose that. And persistent left SVC is one of the most common benign variants. And in most cases, it really doesn't need any particular procedure after birth. Just since somebody asked this question, I will suggest that even in a persistent left SVC, it is good to ask for an echo after birth routinely, not an emergency, because there is this entity called unroofed coronary sinus in persistent left SVC. There could be a problem because the left SVC drains into the left atrium. Otherwise, the left SVC drains into the coronary sinus and the right atrium. So just to make sure that the coronary sinus is completely roofed, it is good to do an echo after birth. So roofing of the coronary sinus is something very difficult to diagnose antenatally.
Okay, sir. There's one more question from Shilpa. In DORV TOF type, are the great arteries parallel? She asks.
No, Shilpa. In DORV TGA, TOF, what was the question? DORV TGA or TOF type? TGA type. Sanjeev?
We TOF type, she's asking, sir.
Okay, TOF type. TOF type in DORV, it is exactly like TOF only, Shilpa. You don't really need to worry about that. You cannot have parallel outflows at all. Like in DORV, the great artery relationship can be extremely variant, So the most common type is where you have, something like a normal relation, what I call side by side, but it's mostly normally related. The pulmonary artery will be anterior and to the left side. In TGA, it is, of course, the aorta will be anterior. In TOF type of DORV, that you won't get parallel outflows. It will be like normally related, like a TOF only.
Okay, so there's one more question. This is from Rahul Shah. What is the role of myocardial performance index in cardiac anomalies? Does it have a role?
Yeah, it's a good question. And myocardial performance index is mostly done as a measure of cardiac function. And it's a very good measure. In fact, it's MPI is something which you can use for a global cardiac function. It's a pretty nice, simple thing, and which I think you know how to do it. It's also called a TI index. There are two settings in which we use this. Of course, for the fetal medicine, the non-cardiac anomalies, you have various situations like I think the most important condition would be the fetal growth restriction or IUGR. That's very, very important. Then fetal anemia, twin-to-twin transfusion syndrome, maternal diabetes. These are all situations where you can do it. Cardiac anomalies per se, the data with MPI is less there. I think there are some conditions like aortic stenosis with LV dysfunction and all where this has been used. But I think most of the literature of MPI is with the other non-cardiac entities like what we discussed. And maybe again, cardiac function is another vast topic. There are a lot of things which are coming up, like the fetal HQ heart quantification software, new methods like global longitudinal strain. But these are all difficult, complex, but a very simple entity. What you showed is MPI TI index. I hope you know how to do it. It's preferably done using the LVOT Doppler, where you get the mitral inflow, E and A waves, and the ventricular outflow as a V wave. And then there is a very specific way to look. There are I think maybe sometime I would like to show that because it's something which is very, very important and how to do it correctly. But I think mostly non-cardiac settings, relatively few applications in congenital heart defects.
Okay, sir. Before we take, I think Dr. Varsha Sarda has answered the fourth quiz. Of course, we are not giving any prizes for that, Varsha. But thanks for that. I think she has the right answer. But let's go on to some more questions. Anjali asks in AVSD, how to do measurement to calculate ratios if it is unbalanced?
Okay, this is Anjali Kulkarni or some other Anjali?
It's just Anjali, sir. I don't know.
Okay, right. Unbalanced AV septal defect. Again, I think these people are really advanced, Sanjeev. I thought, since you said there are a lot of students listening to this, I made it a little more simple. But now when I listen to the questions, I should have complicated this lecture a little bit more. Anyways, how do you differentiate between balanced and unbalanced question is something which I have been trying to figure out for the past 20 years as a pediatric cardiologist. There are no real things, but generally what we do is if you imagine a straight line along the ventricular septum going up, and you split the atrioventricular valve in a single valve, common AV septal defect, into two parts, the right part and the left part. Typically in a balance, both parts will be something like 50-50, roughly. And you call it unbalanced when one part is about more than 2/3 of the other. So it's one part is 2/3 above and the other part is 1/3 above. That's what's called a 67% rule or 0.67 rule. That is where you call it an unbalance. When one of the valves is having less than 33% commitment to that corresponding ventricle, then you are not going to really enjoy a biventricular repair in those cases.
Okay, sir.
Yes.
Anupam Balas, does a prominent right atrial appendage need any follow-up at all?
Okay. Recently, we had a case of a prominent left atrial appendage, which is showing up in the three-vessel view. And, there is this crazy entity called diverticulum from the cardiac chambers. You have RA appendage diverticulum, LA appendage diverticulum, and sometimes RV, LV, and so on. Mostly they are benign structures. The only thing you may just want your cardiology colleague to have a look at this child after birth, just to make sure that there are no clots sitting in there. Sometimes it may cause some stages of blood there, and sometimes clots. But generally, the right-sided lesions are okay. It doesn't. Most of the RA appendage and diverticulum are generally benign entities. The only two things which I mentioned are thrombosis, rarely. Sometimes they may cause slightly higher risk of arrhythmias, ectopic atrial bleeds, and so on.
Okay, sir. I think we've come to an end to the. There's one more question, sir. We'll take it. It's from
yeah.
B. It's from B only. There's no name to that. How to diagnose premature closure of ductus arteriosus?
Okay, right. I think I did not specifically mention the diagnostic clues. Right. So the clue will be the three-vessel and the three-vessel tracheal view, particularly the 3VT view. So normally you have in the 3VT view the pulmonary artery which continues down as a ductus arteriosus, joining the aorta and the aortic arch together in that confluence. So in this entity, typically what you will find is that the ductus arteriosus end will be totally shut off, or we cannot even see the flow there. So that is the first thing. If you put Doppler in there, you may get almost sometimes you may get a continuous flow into the ductus arteriosus with very high velocity. So these are the two important clues. The sagittal view of the ductal arch again will show a complete discontinuity between the proximal PA, proximal duct, and the descending aorta. So continuity will be lost. That is the direct clues. The indirect clues, of course, will be right heart enlargement. You may find right atrial enlargement. You may find tricuspid regurgitation. You may also find right ventricular enlargement. And another very interesting thing which I have found is that when there is a significant constriction of ductus arteriosus, the main pulmonary artery, the PA pressure will be high. So when you put the Doppler across the pulmonary valve, you often get a very low velocity flow. That's the reason because the right ventricle and the pulmonary artery almost have similar pressures because the distal constriction of the duct. So the flow into the pulmonary artery will be substantially reduced. You may even find significant pulmonary regurgitation also. So direct clue is from 3VT view imaging and continuous ductus arteriosus flow, and indirect clues from this host of the other things which I mentioned.
Okay, so I think Kevna has asked a question, but I think you answered it partly. Is there any way to pick unroofed coronary sinus in cases of absent SVC with left SVC?
Okay.
Yeah.
Yes, I have not answered that question, but there is a very specific view called a parasagittal view for the left-sided SVC where you can suspect, but I think it is perhaps too much and too risky also. So it's always good to have an echo after birth for these cases. I think it's much better because I find it very difficult to, the unroofed coronary sinus can be very, very tricky. So it's good to do an echo after birth. Yeah.
Okay, so thank you. So that, okay, there's one more question which has come in from Latia. Isolated coarctation of aortite isthmus. The question is 4-chamber view is good. There is no VSD. There is no left SVC. Z score -1. So
Z score of what is -1? Isthmus. So it's probably isthmus Z score of -1 is not really coarctation. -1 is I think I forgot to tell one important point about the Z score. Z score, you say there's a range of normal, Z score, when you say 0, that means median value, right bang on the middle. Then you go on both sides, you have +2. Up to +2 is the upper limit of normal, up to -2 is the lower limit of normal. So 0 to +2 to -2 to +2, that's the normal range. Outside that, we say it's abnormal. So when you say -1, it is just means it's a bit smaller, but doesn't really mean it is terribly small. So mostly in such cases, coarctation is a less likely a possibility.
Okay, so I think that brings us to the end of these the Q&A, at least for this lecture. It was wonderful, really, and you've really answered all the queries put through very well. We can move on to the other one, sir, the arrhythmia one. And I thought I told you to keep it simple, but you can do it your way if you feel the listeners are very good.
Take an audience poll, Sanjeev, and ask them whether they are game to stand up for another 1 hour.
So we can start, sir. Let us see. Yeah,
okay,
we can get started.
Fine.
But we'll keep it how we discuss, so that's all right. Not a problem.
Yeah. I'm
Let us
going
get
to
some take-home message at least should be there for, because
Yeah.
there are about on our email what we can see about 150, 175 residents are watching, and they've sat through another hour and a half. So arrhythmia, some take-home points would be nice, sir. We can get started.
Okay. So what I am going to do in this lecture, Sanjeev, I may actually skip through a lot of some slides so that I will show them some common examples which they should not miss. Okay.
Surely, sir.
Rather than if I go through the full lecture, it will take a lot of time. But I see 472 people up and watching at 10 o'clock in the night. So obviously, I am not anyone to disappoint them. Okay, so I'm going to allow the screen share again. And let us go back and close this presentation.
Yeah, we've put a poll of the group also, so let us see if they can sit for 1 hour more. So
if they sit for 1 hour, you have to give some real appreciation to them. Okay.
Okay. Right. Let's get started, sir. We can see your screen. Yeah, great. You can start, sir.
Okay, fine. So now this is obviously ideally not a lecture for 10 o'clock in the night, but I know Mumbai and I know my friends in Maharashtra, and I have done sessions there in Nashik in particular. They have never left me idle. They have always kept me busy. So obviously, I would happily do this. Now, fortunately for most of us, most cases are benign. But then there are certain situations where the arrhythmia can be sustained, and that is what we are going to talk about. One simple beginning rule is that tachycardia is mostly present in the third trimester, 28 weeks plus. Very, very rare for tachycardias to happen earlier, before the third trimester, while bradycardia can happen at any time. Typically, they can even happen around mid-trimester, 16, 18 weeks. So it is important to make this distinction that tachycardia typically is an early, it's a late presentation, while bradycardia is a very late, it can happen anytime. Now, I am going to show this particular slide because I think this is what radiologists really want. How will you evaluate an arrhythmia? I think that is going to be an important thing. And I actually propose 3 simple steps. The first thing everybody can do is very easy, fetal heart rate. The second more difficult step is the rhythm, so which I'm going to discuss in some detail. And the third is to evaluate the structure, because sometimes some of the rhythm problems can be associated with congenital heart defects, while some of them may be having normal hearts as well. So the fetal heart rate, I think it is very easy, and I don't think I need to explain how to take the fetal heart rate. Any Doppler is useful. Anywhere, umbilical artery, anywhere you can put a Doppler, you can get the heart rate. So that is done. Now this is a more difficult step. That's the rhythm. So I'm going to discuss a little bit about this here, the rhythm. And I use 2 methods. I use M mode, which is a little bit strange for many of you. So that's why I wanted to show this. And I also use pulse wave Doppler. Most of the time, you can do your business with the LVOT pulse wave Doppler. There is also another type of pulse wave Doppler called the SVC iota Doppler, which is done for a very specific purpose only. The other sides are pulmonary artery, pulmonary vein, descending aorta, IVC. We don't do that. So most of the time, we assess the rhythm using pulse wave Doppler and the M mode. So M mode is, since it's a bit new to many of you, I'm going to show you that. So this is how you do M mode. The cursor has to be directed through the atrial and the ventricular walls. So simultaneously, the atria and the ventricle should be sampled. And this is what you get. And you see the picture there. All the A's are showing the atrial activity, while all the V's are showing the ventricular activity. And typically, as we can see from the graphic above, there is that line is not exactly vertical. There's a slight slanting line. That is because it takes a little bit time for the impulses to move from the atria to the ventricle. That's a normal atrioventricular delay. That's the reason why always it's like a step ladder. There's a slant from the atria to ventricles like that. So here also you can see the little slant. That little delay is a very normal thing. So some of the newer machines have this called the anatomical M mode, where you can rotate the M mode cursor. So even if you have difficult fetal life, the cursor can be rotated, so you can get very nice M mode like what I have shown here. Atria at the bottom and the ventricle on the top. In the pulse wave Doppler, for the rhythm, how you do it is you put it in the LVOT here, and you can get a typical picture like this. The atria has got two waves, the E and the A wave, and the ventricle has got one wave, that is a V wave. And it's a higher speed, you can very nicely see the E and the A and the V. Now this is very useful because you can measure the atrioventricular interval from the beginning of the A to the beginning of the V. And here it is 99 milliseconds. Now why is it important? One of the first signs of heart block in the fetus is prolongation of the AV interval. Typically, when it goes above 140, then you say it is abnormal. Okay, so the simple thing in the rhythm is that when you say rhythm, you say there is a constant relationship between the atria and the ventricle. First the atrial activity and then the ventricular activity. For every atrial activity, there is a ventricular activity which is ensuing. Okay, so that is what we call rhythm. I think this I will probably skip because I think this is a little difficult at this stage, so I don't want to do that. The SVC iota Doppler. Right. So this is the basic concept of rhythm, heart rate and rhythm. Now the third step is the assessment of the cardiac function, which is by the cardiovascular profile score. This I think many of you know by using various parameters, presence of high drops, umbilical vein and ductus venosus Doppler for reversal, etc., heart size, umbilical artery Doppler, looking at various degrees of compromise, and you can actually a more compromised fetus means the arrhythmia is very, very severe. So every arrhythmia, preferably you should assess the function also. Now, as an obstetrician, if there are obstetricians listening, I presume less, it's important that the mother is also looked into maternal illnesses, particularly the thyroid diseases. A lot of tachycardias can have associated abnormalities in the mother's thyroid. Same way, bradycardias, many of them may have an autoimmune mechanism. And I always get, if in a very severe arrhythmia, the maternal investigations would include RFT, LFT, electrolytes, and so on, because we may have to treat the fetus with the medicines by transplacental therapy. Now, there is this very, very rare entity called long QT syndrome. Some of you can log in next Saturday. I think it's at 7 o'clock. We have a full 2-hour session on arrhythmia. I'll send links to maybe Sanjeev. This is a arrhythmia symposium I'm doing next Saturday. So it's 2 hours. So I will talk about this entity called long QT syndrome in that, because it's you need a lot of time for that. It's a very, very rare anomaly. So I'll talk about that. That is where sudden cardiac death. Right. So this slide is important. So I'm going to base my lecture on this slide, and I'll try to cover some of these common things. So the first is premature contractions, and this is usually premature atrial contractions. This typically cause irregular heartbeats, but they are really fine. So they are very benign and they don't cause much problems. The second group is called tachycardias. Typically, the fetal heart rate is more than 200 and it is sustained. Not just 200 flash in the pan, but it remains at 200 for a pretty long period of time. So that is called fetal tachycardias. And then you have fetal bradycardias, which typically I say the heart rate is less than 100, but the most severe forms of bradycardia, the severe forms of bradycardia have heart rates less than 60, 70, sometimes even less than 50. When it is less than 50, then I'll be really worried at that point of time. So the first step, let us talk about tachycardia, is to determine whether that it is a sustained tachycardia or it is just a something which scares you and goes away. So I say that, let us see, if you're seeing the patient 2-3 times during a half an hour, 45-minute period, usually we don't let them go so fast. We ask them to wait, just make sure that what we are seeing is there always. If it is just coming and going, then you call it not sustained, and usually they are ectopic beats. So this is an classical example of an atrial premature beat. So you see here, this is a spectral Doppler, and you see there and there. We can see 2 beats, and if you look at the 2 consecutive beats, you can very clearly see that these beats are happening a bit early. And typically it gives you an impression that the rhythm is irregular. But these are beats which are happening early, so that's called premature beats. And most of the premature beats are premature atrial beats. So this is a spectral Doppler of the same. So there are 2 types of premature atrial beats. The first is called a conducted beats. And this conducted beats means that the atrial beat, a premature beat, will be followed by a ventricular beat also. And the second type of premature atrial beat is where there is mist, doesn't conduct. So there is no ventricular beat. I will give you examples of both. First, in this, I am going to show you example of a conducted beat. So you see the M mode here, and on the top we see the atrium, and the second on the bottom we see the ventricle. So A is atrium, B is ventricle. And here you see the premature atrial beat, and that's what is happening here. You see that is happening early. If you see the gap between 2 normal beats, and if you see the gap between the normal beat and the premature beat, it is narrow. And what is happening here? This beat is getting conducted to the ventricles. That's what is happening here. So there is a premature ventricular beat also because it's a conducted ectopic. So this is, and then after the beat, you see there is a long gap between the 2 beats. That's called a compensatory pause. So premature atrial beat can be of 2 types, conducted to ventricles or not conducted to ventricles. Characteristic feature is there is a shorter gap between the preceding beat and this premature beat. And there is a longer gap between the ectopic beat and the subsequent beat. That is called the compensatory pause. So M mode is beautiful because it nicely tells you these features in a very nice manner. So this is one of the most benign arrhythmias, and fortunately, most cases of arrhythmias are premature atrial beats. Sometimes you will find them happening in a very alarmingly great frequency, but as long as they are premature beats and no fast heartbeat, then you don't need to worry about that. Okay, so this is the most common type of arrhythmia, that is premature atrial contractions. Now let us go to fetal tachycardias. So by definition, the fetal tachycardia means FHR is more than 200. And the most important step is to assess the atrioventricular relationship, which is I assess using the M mode. There are 3 kinds of differential diagnosis here. The first is where the atrium and the ventricular beats are equal. So there is a 1-to-1 atrioventricular relationship. Typically, these are the supraventricular tachycardias. I'm not going to discuss the differential diagnosis because I think it may be a little bit complex and needs a lot of more time. We will have that. Some of you who are interested can log in for the next session because I have much more time, 2.5 hours of arrhythmia. So there I will discuss what is short VA, long VA. But generally, please take it from me that when you have an atrioventricular relationship of 1-to-1 with tachycardia, that is SVT. There are different types of SVT. These are, since I am a cardiologist, I always like to use this kind of short forms. Like AVRT is AV reentrant tachycardia, then atrioventricular AV nodal reentrant tachycardia, which is AVNRT. EAT is ectopic atrial tachycardia. PJRT is paroxysmal junctional reentry tachycardia. These are all different names. Generally, these are all together called as supraventricular tachycardias or SVTs. The second group here, the classical feature is the atrioventricular relationship is 1-to-1. Then you have a situation where the atrioventricular relationship is more than 1:1. That is, there are more atrial beats than there are ventricular beats. This is atrial flutter. And the rare type, I have an example of that, which I will show you. I have to open another presentation, but I will, again, maybe I should, maybe I'll see, depending on how time goes, because yes, we will see about the third one. So that is ventricular tachycardia, where there is a ventricular rate is more than the atrial rate. So this is a very simple algorithm, heart rate and atrioventricular relationship. Okay. So let us see the first case. This was referred to us at 30 weeks because of fetal tachycardia and hydrops fetalis. And look at this heart. I mean, it's just, I think sometimes when you do online programs, it's also a form of tachycardia treatment. As low internet is transplacental therapy, it slows down the heart rate and makes the tachycardia look normal heart. Like yesterday when Sanjeev and I were doing the rehearsal, he said, yeah, I mean, depending on the internet speed, this tachycardia was going and coming. But for me, when I look at the screen, it's a terribly fast heart. And I can't even count. The atria seems to be just going crazy. Right. So my first step is to look at the FHR. I put Doppler somewhere, and I got the heart rate of 234. So obviously, the rate is high. Then I did the M mode and looked at the atrioventricular relationship. And you see on top of the atria, there are several atrial beats, and on the bottom you have the ventricles. And the ventricular rate was coming as 234. So the atrial was very high, 500 plus. So let us look at our algorithm here. So the first step, we looked at fetal heart rate, 234. So it defines tachycardia, no questions. More than 200 would be tachycardia. Then we looked at the atrioventricular relationship. So there are more atrial beats than the ventricular beats. So these are the atrial beats which have been conducted, and these are all blocked. So the diagnosis is atrial flutter. So atrial flutter is a tachycardia where you have tachycardia and there are more atrial beats than the ventricular beats. So some of the beats are blocked. The reason why 514 beats cannot go to the ventricle in 1 minute is simply because the AV node will act as a gatekeeper. It cannot allow so many beats to go across. So it just stops these beats, and that's why you get the AV block. So this is atrial flutter. So this is, again, a very common type of tachycardia. Typically occurs at about 30-32 weeks. So that is the first one. So this was atrial flutter. Now let us see this one, which is again a 30-weeker and referred because of fetal tachycardia. You see the four-chamber view, the heart is racily beating, but unlike the previous one, there isn't so much of pericardial effusion here. But there is ascites. You can see the ascites here. That means that hydrops is developing. So it's not a good situation. Again, the first step is to look at the FHR, and I did that. The heart rate is 279. So obviously, it's a pretty fast heart rate here. Then I looked at the M mode, and I got, what did I get here? The atria and the ventricle are almost same. Ventricular rate and atrial rate both are around 270. You can see on top how I put the cursor so that it is gone across both, and I get both nicely. I'm skipping this because this is like, again, it's okay. That's looking at the SVC iota Doppler here, and I got the VA is more than AV. We can skip that. It's okay. So here, the first step, the algorithm. Fetal heart rate, more than 200? Yes, it's 279. So there is tachycardia. Looking at the atrioventricular relationship, it is 1:1. Every atrial beat is going to the ventricle. So that is SVT. The third step was helpful for me because it's a long VA tachycardia, which tells me that's it's a big deal. It's like usually the PJRT is a type of tachycardia where the VA interval is long. So that's why it's very refractory. So it needs multiple aggressive drugs. So that is the reason why I do it. But even if you don't do the third step of SVC iota Doppler, even if you do the first two steps and distinguish between SVT and atrial flutter, that is a pretty good, achievement. Atrial flutter, atrial rate is more than the ventricular rate, and in SVT, the atrial rate is equal to the ventricular rate. Now, we have very strong protocols for managing these cases, which is what we are just showing this. We give typically multiple drugs, combination of digoxin and very, very strong drugs like flecainide or sotalol. This is what we do. For hydropic fetuses, we give direct intramuscular injection of digoxin to the fetus as well. And this is what the atrial flutter case, we gave direct fetal therapy and converted it into sinus rhythm after 3-4 days. So this was a very, very sick baby, the atrial flutter and high drops, and reverted to sinus rhythm with aggressive therapy. And we'll skip this step here. And so generally the prognosis is very, very good for tachycardia. So it's something which is should be aggressively managed always. So that much about the tachycardia. So you need to remember SVT and atrial flutter, and you also should remember that the most common entity is ectopic beats, which is atrial ectopic beats. Now I'm going to just quickly show you some examples of bradycardia. I think we are okay. We'll take about 15 minutes more. And in fact, it's almost on time because I think I started my session by around 8:30 only. So it's reasonable. So we are giving you reasonably useful messages which you should take home. The definition of fetal bradycardia is an FHR of less than 100, which is sustained. Just like the before, we look at the atrioventricular relationship and see if it is a one-to-one relationship, it is called sinus bradycardia. If there are more atrial beats than the ventricular beats, then we call it atrioventricular block. And this is a very, very important difference. I think this is something which I wanted to show because 2-to-1 atrioventricular relationship, there are two types. One is blocked ectopics and the second is a true block. And I'm going to show you examples of both, how to distinguish between the two. And the third is a complete atrioventricular dissociation where there is no correlation between the atrial activity and the ventricular activity. So that is called a complete atrioventricular block. So sinus bradycardia, blocked ectopics, second degree AV block, and complete AV block. These are the four common entities of bradycardia. The first one and the last one are pretty easy, while it is much more difficult to distinguish between blocked ectopics and second degree AV block. So I'm going to explain to you with an example of that. All four we will see cases. First case example here, the heart rate is 88 here. So and this is the M mode. And we can see that the atrial and the ventricular rate are both the same at about 83. Every atrial is conducted to the ventricle, but overall the heart rate is low. So this is an example of sinus bradycardia. Usually, sinus bradycardia indicates systemic causes like maternal conditions, placental insufficiency, and so on. So normally, and sometimes there are conditions in the fetus which can cause sinus bradycardia. Long QT is one. Long QT syndrome is one such condition. So where you can get sinus bradycardia. Now this is a really interesting case. This is a 19-weeker which is referred as a heart block. And this is how the heart was contracting, and it was obviously slow. When I did the spectral Doppler, this is what I got. I thought there are more atrial beats than the ventricular beats. So I thought from a spectral Doppler, you can see that there are lots of A's and a fewer number of B's. I thought there are 2 atrial beats to 1 ventricular beat. So initial impression was, okay, are we dealing with an AV block here? M mode, then I got this, again the M mode, which is very nicely illustrating it. All the ventricular beats are shown by V and the atrial beats are shown by A. And we can see that for every 2 atrial beats, there is 1 ventricular beat. So it appears to be having a 2-to-1 atrioventricular relationship. So we have the differential diagnosis. Is it a true AV block or is it a blocked topic? So how do you distinguish it with that? So these are all the beats which are conducted, while these are all the beats which are not conducted or blocked. So every second atrial beat is not conducted. So the question is that second beat actually a real beat or is it an ectopic beat? So how do you distinguish? For that, we look at the intervals, AA intervals. That is the time interval between two consecutive atrial beats. So this is what is the normal beats, and these are the second beats. So you can see that every second beat is actually having a short AA interval. That means that every second beat is an ectopic beat, and that is not conducted. So the classical feature is that the AA intervals were not constant, they were varying. Every second atrial beat was blocked, so it is not a true atrioventricular block, but it is a blocked atrial, non-conducted atrial ectopics. And every second beat was an atrial ectopic. Cardiologists call it atrial bigeminy. That's the phrase which we use, bigeminy, which means every second beat is a ectopic beat which is missed. So there is bradycardia. There is a 2:1 atrioventricular relationship, and the AA intervals were varying. So the diagnosis was blocked atrial ectopics and not a true atrioventricular block. So I just reassured them and asked the lady to come back to me after 2 weeks, and there we go. The ectopics disappeared by themselves, and we had one-to-one conduction with a normal fetal heart rate of 138, and the fetus remained in sinus rhythm throughout. So somebody who was referred at 19 weeks with a consideration for termination of pregnancy because of AV block, in fact, it turned out to be the AV ectopic beats. Happening every second beat was ectopic. The clue was the varying AA interval, not a constant AA interval. This is a very important message. Now let us see this case, which is also referred to me as an AV block. And you can see that here also, like the previous case, it looks like there is a significant bradycardia. The heart rate was 68, very slow heart rate. And now we looked at the M mode. And here also on top, we see the V's and we see the A's on the bottom. So there are more A's than there are V's. These are the A's which are conducted, and these are the A's which are not conducted. So remarkably similar to the first case, the previous case, till this point. Every second atrial beat is not conducted. Only one out of the two is conducted. But when we looked at the AA intervals here, all of them were similar, constant. That's what I've shown here, for around 450. Little bit difference in the numbers are only because of the measurement errors, but mostly the AA intervals have been constant. So unlike the first case, previous case, where the AA intervals were varying, in this the AA intervals were constant. Every second atrial beat was blocked. So here the diagnosis is a true 2:1 atrioventricular block. So 2:1 AV block, the algorithm, the fetal heart rate is low. There is a 2:1 atrioventricular conduction, and the AA interval is constant. So that is a true atrioventricular block. This is a much more severe and important condition. It's not a benign condition, and this is not going to go away. Most of this may be due to maternal antibodies, due to autoimmune disease, or may be associated with heart defects like left isomerism and so on. 2:1 AV block may also be a feature of long QT syndrome. And I have now 6 cases of long QT syndrome in my database. It's such an interesting diagnosis. So we will discuss this next Saturday in the Arrhythmia Symposium in a different session, but I will share the link with some of you, and interested people can join. And I'll show you a case of long QT during that. Now, atrioventricular block, when you look at the etiology, 50% are isolated, and most of them have maternal autoimmune disease. That is like SLE, like syndrome. Typically, the block occurs between 16 to 28 weeks. The first step may be a prolongation of the AV interval, what is called a first degree AV block, and then it may progress from 2:1 block and sometimes even to complete heart block. Second group is associated with congenital heart defects. The common congenital heart defects which are associated with heart block include left isomerism and CCTG. These are the two more common conditions. Okay, now we will see the final scenario for today. That is the example of a complete heart block. This was referred to us at 23 weeks because of fetal bradycardia. So obviously the 4-chamber view is showing good squeeze. There is no high drops, but there is a very slow fetal heart rate. A complete survey for associated structural anomalies were done, and that was normal. First step, pulse wave Doppler, the heart rate was only 50. M mode, as we can see here, the large number of atrial beats, which are normal. The atrial rate was 141, but the ventricular rate was only 50. Very slow ventricular rate. Very nicely shown by this M mode. So, first step, fetal heart rate less than 50. Yes, it was only less than 100. It was only 50. So, there is severe bradycardia. Looking at the atrioventricular relationship, some of the atria are conducted while some are blocked. Sometimes two blocked, sometimes one blocked. So there is no clear relationship between the atria and the ventricles. So that is an example of complete atrioventricular dissociation. That is called complete atrioventricular block. This is also called third degree AV block. This is where the damage is done. There is fully damaged. The AV node has been totally damaged. So in this study, which is a multi-institutional study, which is published in Circulation about 10 years back, the following risk factors for poor outcome were identified for complete AV block in the fetus. Just a diagnosis at below 20 weeks, ventricular rate of less than 50, presence of hydrops fetalis, or impaired LV function. If these risk factors were not present, 90% survived till terms. The algorithm which we follow is that if there are high-risk features, we treat them aggressively. Usually we give steroids to the mother, that is dexamethasone with beta agonist. If no high-risk features are present, we just follow the patients and treat the babies after birth. So this patient was born prematurely and needed pacing and permanent pacing also because the heart rate was very, very low. So in summary, evaluation of fetal heart rate and rhythm are integral in the assessment of the fetal heart. Fortunately, most of the common rhythm anomalies are benign and self-limiting. Tachycardias are an important treatable cause of high drops, while bradycardia often need long-term follow-up, and a good number of fetal complete heart block cases will require pacemaker after birth. So that's why they are much more resource intensive. So I will conclude the presentation with this and stop screen share. Yes. So I will come to Sanjeev for any questions on this topic.
Yes, sir. Thank you very much. We just open the chat box.
Yes.
And we'll just wait for a couple of minutes.
I purposely made it a little sort of very simple because I think, this at least we can give some messages. Next weekend, I'm having a GE-led symposium. It's on fetal arrhythmias. I will share the link with you, and maybe you can ask interested people to join. In that, I will have a long 2-hour discussion with a little more elaborate scenarios also. Okay. Right.
Okay, sir. So many people are saying thank you very much. We've understood arrhythmias for the first time. And Falguni Rambya is asking that could you show us a case of ectopic ventricular beats? I think the video.
Yes, I have. I will show. Show.
All right.
It was there in this presentation. I think this is really very, very good because I will show you the ventricular beat. Since the question was asked, then we can't. I actually purposefully did not show that. Here you see Falguni. You see this M mode, and you see on top the ventricles, and below the atrium. You see one fellow here. The ventricular beat is happening prematurely. And following the beat, you see a slightly longer cycle. See that? There is the ventricular beat. And typically, the ventricular beat is not conducted to the atrium. Obviously, because you can't have that retrograde conduction. That will be a dissociated beat. So, on the bottom, the atrial, that you can see a slightly long interval. So, this is an example of a ventricular premature beat. I also have ventricular tachycardia, but for that, I will show next week because, little bit of suspenses because we have more time next week. Okay. So I will show VT this. Okay. I got messages from Barve sir also from Nashik. And I think so. I'm so
he's not supposed to send you, sir. He's supposed to come through our chat box.
No, he sent me a message just now and Thank you so much, sir. I think he is one of my gurus and wonderful person who has always encouraged, me in my teaching endeavors. Thank you very much, sir, for staying up at 10:30. Yes.
Renu is asking, sir, how do we use anatomic M mode? Where do we put the sample gate?
Okay, anatomical M mode is simple. Basically, you can actually rotate the M mode cursor, in whichever way you want. So what I do is I look at the 4-chamber view, and then in the machines which are AMM, anatomical M mode, you have the option of conventional M mode versus anatomical M mode. So if I am not getting a kind of a nice picture where I can slice through both the atria and ventricles, then I go to anatomical M mode. Then I just rotate the cursor in such a way that I cut the M mode, because you can put it in any angle you want, not just perpendicular or horizontal. Any angle you can put. So ensure that ventricle I take right through the middle of the ventricular wall. Atrium, it's a little bit of I think I will give it. Why should I keep all the trade secrets with me now? You have to find a little bumpy part on the atrium. It's not a very smooth wall. Some areas of the atrium will have a little bumpy parts. Put that cursor there, then you get a nice tracing. Otherwise, the atrial wall is far smoother than the ventricular wall, and you may not get a nice atrial tracing. But just find that little bumpy part, the little fluttering part in the atrium where you put that cursor over through that, and then you get this nice tracing in the atrium as well. Particularly in atrial flutter, when the atrium is just blasting away at 500, 600, it is very, very difficult to get the contractility of the atrium, because it's just almost like a quivering bag of worms when it is fluttered.
Okay, I'm just waiting for more questions, sir.
I think this was one of the most marathon sessions I have done. 10:30 in the night,
It's gone beautiful. So we have 400 people still there.
Yeah, it's amazing actually. It's just, I think that tells a lot that people are interested.
Yeah. Sushil is asking. Yeah, sorry. Sushil is asking, will we get such images if patient has a regurgitation?
Of tricuspid regurgitation?
Yes,
Yeah,
I believe so. Yeah.
Yeah, I think so. It shouldn't be a problem, because your atrium will be, most of this will have some amount of tricuspid regurgitation, because the heart is dilated. Often there will be dysfunction, so it shouldn't be a problem. What I want to tell this 400 people is that you please go and try out M mode. Just you don't become you're not going to get pictures of arrhythmia straight up. It's a pretty difficult thing. You have a fetal tachycardia, you are scared yourself, and you don't know what the hell to do. And don't try M mode in an arrhythmia patient. First, try it in normal patients. When you scan patients from tomorrow onwards, start with the M mode with 2 or 3 patients, the best ones, where you get the best windows. Try it, and then after, slowly you will become more and more comfortable with this entity.
Okay, sir. So just one simple question also I want to ask you, sir. I've got it on a private chat. Is that suppose the heart rate of a patient is persistently 180,
okay,
baby,
yes.
and everything's normal. We looked for everything. What do we do next? It's gone just above what we normally get. So what do we do?
Yeah, it's a very good question. It's actually, in fact, it should be a public question, because everybody needs to know the answer for this. Yes, I think we are almost on, on something like a fence sitter here. Some people may call this as a tachycardia. Others may say it's the upper limit of normal. I will follow up these patients, something like maybe in a week, every week for the next 1 or 2 weeks. I will also check the mother's thyroid profile, and heart rate of 188. There are some slow forms of tachycardias, rare forms. It could be one of those. But in the first step, I won't start medications immediately. If the heart is normal, squeeze is good, no pericardial effusion, no signs of high drops, and then I'll just sort of wait, see the patient after maybe a few days, and then if the heart rate settles, I'm good. Thyroid levels should be checked. It's important, because sometimes maternal hypothyroidism can have these kind of things. So this is what I would do in the first evaluation.
Okay, sir.
If it's persistently high and there are signs of possible compromise, then I may just add digoxin, just slow the heart a bit down. But otherwise, I'm fine. I don't want to treat them straight away first step. Okay.
Okay, sir. There are no more questions. We'll just wait for a few seconds more, sir. Then we'll close if there's nothing else coming.
Absolutely.
If anyone wishes to ask anything from sir, I think sir's in a great mood to tell us everything he wants to and can. So you can
I
please
am
type in the
actually
chat box.
feeling like, doing one more lecture now.
Yeah.
I really enjoyed this, Sanjeev.
Okay.
I am always a doubtful starter. Before a webinar, I think I can't do it. I'm tired, but after the program is over, I feel good because I just enjoy doing this whole thing, and so it makes this sessions. And unfortunately, we are not able to meet. But I'm looking forward to Mumbai meetings. I don't want virtual meetings. I want real meetings.
So
It's my
Mumbai,
favorite city.
we'll be having sir this year for sure. Sonobuzz year end or Jan. So we'll call you for that, sir. 100%.
I want to
Yeah.
come. I want to come to Mumbai.
We'll get you, sir. We're getting one question from Davis. Davis is if I'm getting the person correct, he's based in Dubai and he's done a lot of work on music and how it affects the fetus. If I'm getting that right.
I know Dr. Davis. He's
Yes,
a good friend of mine.
that's right. So he's asking you, what is the relation between music and fetal heart rate?
I think it will relax. So obviously, it should slow it down. But I haven't studied this, but I think he had actually told, and I had this discussion with Dr. Davis once, that one of his fellows had done an NICU study in which the newborn heart rates they had done using music. So it depends on what type of music. I think, if you have Metallica playing, then it may be a bit fast. So if you have something like a nice Hindustani, classical one, then it should slow it down. And I really feel that it should be a relaxing property, and it should slow it down. For our heart rate slow down, and I see if the mother relaxes, and then the baby's heart also relaxes.
So
I think
you're saying it's more through the mother's heart rate going down than the baby.
It is mostly. I don't know. I don't have any scientific evidence from my side, but I think Dr. Davis has done some work, and he should be in a much better position. I'm not an expert about the effect of music on fetal heart rate, and so I would not take away any of his observations. I think he is more likely to be correct than me in this point. Yes.
There's a question from Praveen, sir. Describe bigeminy and trigeminy.
Okay, a bigeminy is a situation where you have every second beat, which is typically missed, like atrial bigeminy case, which I showed. Trigeminy is, of course, the third beat. So obviously, these are all a little more, serious types of ectopic rhythms. When you have bigeminy or trigeminy, these are the very ones which can actually degenerate into a tachycardia. Even though we showed that, of course, it's a differential diagnosis of bradycardia because some of them are blocked. But actually, the effect of these rhythms is that sometimes, when we say that the ectopic beats falls on the wrong part of the cardiac cycle, right on what we call the R wave of the ECG, it may just trigger the atrial tachycardia. Mind you, most of the atrial supraventricular tachycardias have an ectopic beat at its source. It's a match which lights the fire, the forest fire. So sometimes some of these malignant ectopics like bigeminy, we need to watch it.
Okay, sir. I'm just waiting. I think there's one more. Kailad Dule is asking, what's the average weeks to pick up a cardiac anomaly? So.
Okay, I think it's a very broad question, and I mean, there are some of you who pick it up at 11, 12 week scan, and Rabi and others are now, Simon from Australia, he showed me a case at 9, 10 weeks also. So I think those are the people who push the field forward. For me, I am okay with around 13, 14 weeks. I'm good. I don't do much first trimester, so I can't claim that I'm very good in that. But my mid trimester, I think all the things which I showed you should be, we can pick up. And it depends on a combination of three factors. I think one is, of course, fetal position and the maternal habitus, which is for everyone. Then your expertise and then the equipment. I think in the order, these are the three factors. So I think most of the things which I showed you you should be able to pick it up well before 20 weeks. But I also will say that even in the third trimester, please do not hesitate to look at the heart. Sometimes anomalies like coarctation or anomalous pulmonary vein drainage, etc., may be picked up more in the third trimester than in the first or second.
Okay, sir. So one more question. Can you, Rupali is asking whether you can speak something on atrial fibrillation.
Okay, that's a very good question. I think it's a very good question. In the fetus, atrial fibrillation is not so common. It's like a pretty rare arrhythmia. Much more is atrial flutter is something which is more common. Now, how do you differentiate in theory between atrial fibrillation and atrial flutter? Now, atrial fibrillation means the two atrial beats, they will have absolutely no relation with each other. They will be very irregular. And the classical, Hutchison's clinical methods used to describe the pulse in atrial fibrillation as irregularly irregular. So that's a kind of a thing. There is no order to even craziness in atrial fibrillation, while in flutter, even though it is crazy, it's an orderly crazy. So it's a disorderly crazy is atrial fibrillation. So there is, between the two atrial beats, there is absolutely no relationship. It can be fast. Two A intervals can be fast. It could be slow. It could be, vary. And obviously, the atrial rates will be fast. So it's very similar to atrial flutter, with the exception that in flutter, the A intervals tends to be reasonably constant, while in fibrillation, it is not constant.
Okay, sir. One question from Anupam Bhalla. How do we differentiate a true bigeminy from breathing movements, mimic?
That is something which probably someone else, I don't think when you put stuff like pulse wave Doppler or, surely pulse wave Doppler MOD, the breathing movements should not be hampering it. I think so. And because most of the time in the third trimester, you are likely to deal with some amount of breathing movement. So I think it is probably, you should be able to make it out if you really get your sections of both the pulse wave and the MOD right. It's on the heart, the way I told you, across the ventricles and the atrium, which I showed you. Should not be a problem. Yes.
Okay. There are a couple of questions coming up. So, like someone's asking how much time we need to give for a fetal echo routinely. So, what would be a survival guide for most of us? At every stage of pregnancy, I would say, okay, anomaly scan, I would say, I'll do a detailed cardiac assessment, yes. But when the patient comes then to us at, let's say, 28, 30 weeks and then at 36, how much time should I give at 28, 30 weeks? How you said, we can see coarctation later. And how much time should I give at 34, 35 weeks when the patient comes for a Doppler or just a growth interval scan?
No, I think it's a very good question. I think at every stage, even in the third trimester, I think you should do the basic views, the 4-chamber view. If there's something, then it's all this question of how sharp you are observing. The TAPVC case, which our colleague diagnosed, was essentially there was a right-left asymmetry, and the left atrium did not look good. She couldn't see the pulmonary veins joining the left atrium. It looked more like the back of my head from behind. You are not seeing the back of my head. It's all bald, no hair. Okay. So it looked bald. So it's like, so then it got, and then we got into the 3-vessel view, and instead of 3, she saw 4. And that's how the whole thing came. So if you are seeing the basic views, the 4-chamber, the outflow, the 3-vessel, and if there is anything which is out of the normal, which you feel, then you should really pursue it and try to get and see whether there's something that's really wrong. So I think the clues will be a proper application of the basic views of the heart, the 3 views, and looking at it intently. Maybe spend about 5 minutes on this. And if there is anything abnormal, then it is worth looking in a much more detailed way.
Okay, sir. I think that brings us to the end of all questions. There's nothing else coming. The only thing people are writing is for your link that they want from me, and they're going to hound me all week. Yeah. So I'd request you that as soon as you get this link, you could please send it to me. So I'll share it on all groups.
I am actually, the lecture on arrhythmias will follow a very similar pattern, but we will have a little more cases and more time. So I'll do it more thoroughly with a lot of, I am actually going to quiz them also. So they will get questions in the form of a quiz, which they will answer, and then we will have, it will be a revision for people who attended, and that will consolidate some of the concepts which we initiated today. Sanjeev, I really want to thank you a lot. I think this particular event was something which I wanted to do, Sonobuzz, because Mark had told me about you guys, and ever since that, I was looking forward to this. One major event in the calendar which I had missed all these years is Sonobuzz, and I am happy that we could finally sort of do it today.
Yes, you'll be doing it next year also, surely, sir. So we'll call you, we'll invite you, and thank you very much for being a part of this and answering all the queries. I think we've come to an end of all questions from everybody. So it's pretty late, and we still have about 300 plus people here at 10:45. So it speaks volumes about your teaching, and more than your teaching, your passion, the passion with which you teach and explain, every point. Most of the time, we don't ask questions. Even I don't ask questions. We get worried. Is it a stupid question? But no question is stupid, really, right? So it's good that you answered everything, and it solved many problems of all of us, actually.
Okay. Yeah. Thank you, Sanjeev.
Thank you, sir. And bye-bye and good night.
Good night. Today. Good night to everyone. Yeah. Good night. Bye.
Thank you, sir. Yes. And for the rest, we'll end tonight, and we start tomorrow at 9 o'clock sharp. And it's with Dr. Bijoy Balkrishna. It's a marathon fetal imaging session broken in 2 halves from 9 o'clock to 12:30. And then there's an afternoon session with a big quiz contest coming from Dr. Nitin Chaubal. So please come in and tune in for the last day of Sonobuzz. Bye-bye.